Okay, fantastic. A very good morning and a warm welcome to day two. If today goes by even a remote reflection of yesterday, it's going to be a phenomenal ride into a lot of information that was shared and a lot of discussion that happened. I think, truthfully, it was phenomenal yesterday, the amount of interactions which were happening yesterday. And so we all really enjoyed it. We even enjoyed the after party after that, but I shall discuss that later. I think this hall is very the most critical or the soul of the conference, in fact, because we have labeled it as precision medicine at the heart of it. And there was a lot of discussion in inauguration about it. And for that, I would like to start the first session by inviting Dr. Aparna Dhar and Dr. Bowman Dabar. They need no introductions, but Dr. Dhar is head of. Please explain to me. Okay, she's a very close friend and one of the most informed people on molecular and genetic NGS, molecular abnormalities, and a phenomenal help to me and my patients for now, I think, a decade. Thank you. Dr. Dabar, again, needs no introduction. He's the medical oncologist at Fortis, Mulund, and a force to reckon with. Please, over to you, sir.
All right, good morning, everybody. Right, so we kickstart with a panel discussion on pioneering precision oncology practice in India, navigating challenges, embracing NGS advances for success. Our moderators for this session are Dr. T. Raja, a very well-known precision oncologist from Apollo Cancer Center, Chennai, and Dr. Nitesh Rotagi, another phenomenal precision oncologist from Fortis Healthcare. Yeah.
Thank you so much for this invitation. There will be a timer, no? At the end of it, you will be warning us, actually. And I sincerely thank Fortis Cancer Summit organizers, Dr. Niti and Dr. Nitesh in particular for inviting me to be here. And phenomenal meeting, and they have given a very innovative topic. The topic is navigating challenges and embracing NGS advances for success. It's a very kind of a teaser topic, kind of it's just like a lung opener. So let me have the panelists here: Dr. Prachi Madan, Madam, Dr. Umadangi, Dr. Vinayak Maka, Dr. Arun Kumar, Dr. Satish, Dr. Sai Vivek, and Dr. Anand, A.K. Anand.
I think Dr. Anand is running late, so he'll possibly join in later.
Dr. Anand is running late, that's what I'm told. So whenever he comes, we will let Dr. Anand join. And sorry? Sure. Yeah. So good morning to Dr. Natasha. Right. So as I said, the topic is about embracing. That's what it is all about. Embracing is a gentle hug, as you know. It's not. It's gently taking it forward along with us. That's the whole art of what we want to do with this NGS in our day-to-day practice. So we'll start off with this important paper that came in 2022. One of our own Indian author, Dr. Raju Matthew, a very well-known, very respected med-onc, led this paper And he talks about clinical benefit of comprehensive genomic profiling in advanced cancers in India. So what does he want to say? So he says that he aimed to study the clinical benefit of CGPs in advanced cancers in India, and the relevance was that they wanted to look at what happens in low and middle income group income countries. We all know what is the impact in high or well-developed countries. You can look at any data, particularly the data set from MSKCC, which would quote to the tune of 50 to 70% benefit out of CGP. If you want to look at their data set, MSKCC impact data set. But this is Indian data or low middle income group. And this is what he observes. He observes 10% of patients who underwent the testing received a targeted therapy. And out of that, 4% claimed a clinical benefit. So that's almost like a reality check. Okay. So how did the paper go about? So they have taken about 290 or 300 odd patients, and in which they carefully eliminated all those single gene driver mutations, which are like very well established, the EGFR and the HER2 amplification and MET and so on and so forth. And then they took the next 221 patients, and these are some of the ideas about these 221 patients. You can look at the mutated genes column in the toward the right, exon 20 insertions, BRCA1 BRIP, HER2 amplifications, and HER2 copy number variation, EGFR amplifications, and KRAS G12C and something like that. So what they want to say is that these are not yet regularly available standard of care. What happened? And in that, they said 10% targetable and then only 4% derived benefit, and the benefit parameter was how many of them could continue for about 6 months. That means meaningful impact. So these are the reasons they would say that finally why a large number of patients did not get genotype directed therapy, even though something was at least in the literature or in the knowledgeable MDT world possible. So these are all the reasons. They say that the patient, some of them said that there could be some other options the oncologists believed, and affordability, financial constraints, so on and so forth. So I'm turning to my...
Can I just add one more thing to that?
Yeah.
One of the reasons for, I was a part of this, one of the reasons what we're doing was taking out the mutations that were readable without CGP. So really question was CGP versus what the benefit of CGP. So we first took out, for example, EGFR by RT-PCR, and also these were the list which we could have done without CGP, and then we rendered the remaining patients and said if there was a benefit.
Fine. The concept of it. So these are the reasons alluded by the authors of why genomic directed therapy was not possible in more than 1/3 of the patients. And maybe another third, nothing was really genomically possible, but when it is possible, could not be done. So constraints. So I am asking Prachi, madam, what's your thought and what is your real life experience? In your setup, in your centers, you are from the laboratory. So how do physicians, take you for all these things?
So I'm from Jaslok Hospital, and I'm basically a cytogeneticist. Yeah. So karyotyping fish and microarrays, and of course NGS is there, but that is handled by another department. But even then, all these technologies are really important. NGS specifically is important because it is comprehensive. It can pick up from so many different mutations. It can pick up the actual cause. In cancer, even non-cancer for hereditary, genes and all that.
Madam, want you to touch upon the constraints. I mean, that is probably well understood by the initiated audience. Just comment on these constraints.
So in constraints now, one is that if you suspect something common, you don't need an NGS for it. A FISH or a karyotyping is also very good. For example, the Philadelphia positive. Or anything else, even like if it is a 5q deletion, and lenalidomide can be given for that. So,
Dr. Vinayak, so what is, as a clinician, what are your thoughts on the real life constraints?
I was part of the study actually, so we had 6-7 cases. So I think some of the options which comes through NGF, there's no drug available for most of the patients. If drug available is not, access is not possible. And second, reluctance on patients initially, now that we have little lesser cost genomic studies, but at that time when we did, there were hardly patients who would agree for it. And especially they were not acceptable at 4% of the benefit which they're going to get it. So they were the constraints, and they didn't change much. For example, I did for a few of the colon patients who were KRAS mutated, they didn't change anything. So our Indian validated reports were as concurred by even by those advanced tests.
Fine. So, now let us look at some real cases. So I have just divided them as level 1, 2, 3, just for this is my own, just simple way of presenting these cases.
I think we should use that in the future. Actually, SIR's classification may be very useful in our common molecular board discussion.
We'll come to that. So let's touch upon the cases. We'll go right into the cases. This is a bladder, okay? This is a high-grade papillary bladder, and advanced disease, undergoes DGS stenting and goes through chemotherapy, very standard, gemcitabine, carboplatin, and then maintenance with avelumab, and then this is all in March 2020. Finally, after 1.5 years, the disease progresses in March 2022. So that's the time we do this, sequencing, and we get this FGFR TAC3 fusion. So this is kind of a very common, very classical. It's not common. It's a very classical mutation that is definitely pathogenic. That's what we would believe. So therefore, I'll ask, Dr. Satish, clinician, you have this first line treated bladder, second line. So what are your quick thoughts? That's all.
It's a good thing, sir. Like practically will come across like this because without NGS.
So what would you do in the second line with all these info? What will you do?
So we are having a target therapy. We enroll even adrafinib this medication that in a clinical trial. Dr. Govind Babu, myself, we enroll in the study. That's one of the opportunity by NGS. If we get this mutation, we can enroll. But problem is out
Sai,
of
what would you do, Dr. Sai?
that we FGFR inhibitor adrafinib.
Yeah. No, agreed. We have a lot of cases.
Yes.
We'll come to it. Sai, what would you do?
So, definitely would be tempted to initiate on anti-FGFR, but in this particular patient with that 1.5 years of maintenance, I would be really tempted to re-challenge with the first line and then keep the FGFR for later because it's a metastatic case.
Okay.
Can I ask one quick question to Arun also? There was a FGFR amplification also there. Does that have an implication when we are using an inhibitor?
So in this, the amplification is because of a particular just FGFR1 and 3. So it has implications in immunotherapy, but not in chemotherapy. But I think irrespective of that, inhibitors of FGFR would be.
Yeah, this is one of the very classical mutation that's going to self-drive. The FGFR 1, 2, 3, 4, any one of them gets lighted up on the top. It's going to be a self-driving. So as Sai and Satish wanted, we had put the patient on adrafinib. So everything went on well, 6 months progression. And after that, of course, you are liking some more therapy comes into picture. No problem. Another level 1 case. So this is a cholangiocarcinoma, 47-year-old metastatic intrahepatic cholangiocarcinoma, presents with a CA99 of 20,000 plus, and this is in June 2021. So again, this is Dr. Nitesh patient. Gemcitabine and platinum was challenged, and excellent response, and comes to a very good excellent response with some residual disease. The CA99 drops to 900, but eventually progresses in October 2021. At that time, Foundation 1 was done. These are the Foundation 1 changes. I'm going to show the Foundation 1 changes here. This is FGFR2 amplification, and you also have an FGFR1 and BIC1. Again, FGFR2, BIC1 fusion. This is again a very, very classical fusion, particularly in cholangiocarcinomas. And then we have some additional changes. So Arun, to you, a quick read on this. What will you advise the clinician? And then I'll turn to the clinician.
So first thing I would do is recheck, because you had mentioned the non-canonical aspect of the fusion. I would want to recheck if the fusion holds the domain, important kinase domain of the
How do you
receptor.
check, Arun?
So that is
When we
done
have doubt, how
informat-
do we check? You go for IHC, how do you check this?
So first we do it informatically. We see, we have the sequence of the gene. We see in which part of the gene the fusion has occurred. And if that changes the reading frame of the gene. If that is the case, it can just, it could be a random event of a fusion, but not producing an oncogenic protein. So we do have quite a significant number of cases with fusion positive. You'd be tempted to give a targeted therapy, but that fusion would actually be a non-targetable fusion. So IHC is one of the best
This
ways
is
you-
one of the very classical fusions of cholangio.
Yep.
Unless you're going to warn me that you find something different, I'm not able to find out whether there is anything wrong
But
with this.
it's
And
not-
my mind says that target it. That's what my
Agreed.
mind says. I'll ask
Targeting
Nitesh
that
what
is the
went
one.
on in the case.
So,
Nitesh.
I think first of all, it is very critical what Arun said, that we do need to involve the molecular biologist before we take
Obviously.
these decisions.
Yeah.
So, but with this patient, it was actually a driver mutation, and we put him on a FGFR inhibitor in 21, which he continued then.
For 1 year.
1 year, he still continues it. But then at about a year and a half, he started progressing slowly. It was not a radiological progression as much as a marker progression. And finally, there was a radiological progression. So we, in fact, repeated a foundation one at that point, and we gave him a gemcitabine with some 50% dose reduction, really not knowing what else to do, which he had terrible toxicity from.
So even though I have qualified this as a level 1, I'll just go back one step on this particular slide. On this patient also had a PIK3CA E545 mutation, which is actually another very classical mutation. And when these coexist in cholangiocarcinoma, it is as though this pulls the rug under the FGFR. So the targeting becomes a little bit confusing here. And that could explain why you lost your response after 1 year. So we'll go to level 2 cases.
So in that case, would a PIK3 inhibitor in addition to FGFR ever be a consideration maybe for the panel?
So can Satish take it? Would you want, for example, he's on futibatinib, so would you want to add a PIK3CA along with that?
It's a tolerance is
Anecdotal.
You won't get data. You will never get data on these kind of cases. They cannot be a congregation.
So we'll
of
ask
patients.
Madam Natasha on such a situation.
This is not lung, but the question here is you've got a driver mutation. PIK3 is not uncommon
Futibatinib.
as a resistance mechanism. And really, would you ever conjecture the two if other options are limited?
You know, from a lung cancer perspective, increasingly, I feel like we're treating by case study. And so, you know, I think we're learning a lot more about combinations. If you can't get the patient on a protocol, you understand the risks. I think it's not unreasonable. You know, we're always a fan of single agent and then adding if it doesn't work. But, you know, I think this is a new frontier.
Can consider if there is some literature to support. We'll come to level 2 cases. So level 2 cases, little bit. So this is a lung CA, female patient, 63-year-old, metastatic disease with bronchoalveolar features, and PEM-carbo, maintenance, and goes on, progresses, and then we had put the patient on second-line chemotherapy with the dosi pembro. I'll tell you why. Because at the diagnosis we do this profiling, and this is what we get: KRAS G12D, and here again we have a PIK3CA, another pathogenic mutation. Apart from that, we also have a CDK2A and alteration, and 2A and 2B alteration, and we have a TP53 loss of function mutation. So this is the profile.
You start with Arun, sir. Just
Arun,
how do you?
can you throw some light here?
Sure. So it's interesting to see both PIK3 and KRAS in this tumor. Generally, it's quite rare. Now, we have to look into the VAF to see which is the dominant one. Of course, there are no direct therapies to target this. If you have to target, you have to target two pathways, the PIK3 pathway as well as the KRAS pathway. Of course, we don't do that upfront. Can you just go back to the previous one? What was the TP53 mutation? E286K. Okay. So that is a loss of function mutation.
It's a loss of function mutation.
It's a lot of loss of function mutation. In my opinion, I would, I don't know the PDL1 status, but this could be a case which could benefit from ABCP regimen.
Okay.
That's because say
This
KRAS
case, Dr. Sai knows this case. I will quickly take you through this case. So these are the questions like what you asked. KRAS PIK3CA co-occurrence, what do we do? And then we have a KRAS G12D, and of course, you know, there are some papers, and again, if you have a good postgraduate team around, bortezomib, NF-kappa B inhibition in KRAS G12D is talked about. And then TP53 alteration is, what does it do here? So these are all the questions in this patient. So this is what you take out of the literature, and then you say that exceptional responders, KRAS G12D and NF-kappa B, targeting with bortezomib. This is a literature response on bortezomib. So we look at this, and then this is the, if you want to look at the, understand what exactly happens on the pathophysiology, this is what is happening. So NF-kappa B block helps in KRAS G12D. That's the simple bottom line. And so therefore we put this patient on bortezomib. And this is in, if you look at the response, it's really, really stunning response for what you would expect here. This is what happened. So we were so thrilled and so elated. Look at the response. So that's fine. But then comes the trouble. There's another patient. He's a young man, CA lung, adenocarcinoma, 2021. Again, same, PEM, carbos goes on, and then progresses. Here again, then we think about what do we do second line. This is the profiling of the second patient, young man. He has got a KRAS G12D, and then he has got an STK11, and he has got a CARD11. So once again, we will turn to Arun. So inviting the previous patient success is so head toxicity for us, and then we think that we know what to do, and we have a patient. And a young man, actually much younger than the other patient. What do we do?
Quite significantly, the pathways are different here. Apart from KRAS, there are no commonalities. Particularly, the PIK3CA isn't here. And STK11, I have to actually check what effect the proteasome inhibitor has on this STK11. But I think biologically, it's very different. And this could not be a great candidate for immunotherapy either because of STK11. So I think I don't...
Vinayak, clinician.
I think the options are very limited. I would go for a second-line treatment, actually.
Sai?
Definitely no immunotherapy because of the STK11, but based on the history we have with the KRAS, I would be tempted to try it.
Thank you for saying that. That's what we did. So we did the same thing. It did not touch him. It did not respond. So therefore, we put the patient on ABCP, and then he went on for about a year with ABCP, then progressed fourth line. So then we wanted to understand why the same magic did not happen in this patient. The patients, we wanted to re-look at this profile, KRAS G12D, STK11, and not that we are great molecular oncologists like you, but we are trying to figure out what went on here. So then comes the understanding. So I believe, we will come back to a couple of our experts here. The NF-kappa B inhibition is actually dependent on P53 loss. The point is, whenever there is KRAS G12D plus P53 co-loss, then this works. If it is not there independently, the same magic does not work. So that's what we understand. So the point is, so both of them depend on the pathway, somewhere they interact, and therefore this patient did not work. Again, this could be but this is the best possible, closest to scientific we could bring. Again, this could be just a postulation, but we are trying to figure out what went on, so that's what happened. So I will ask, one of our very, very distinguished molecular biologist and artificial intelligence specialist, Dr. Petak is here. So we want to ask your comments on such patients who have gone beyond, let me say, use the word standard of care. So when we go beyond standard of care, when we are faced with this, how much do you think artificial intelligence or bioinformatics will help us to go into that? Can you tell us which way you would solve or help your clinicians in these settings?
Yes, thank you very much. These are excellent cases, and congratulate to you for bringing this to us. So, yeah, so the challenge is that there are hundreds and thousands of actually literature you can be found that are directly or indirectly related to these alterations. And somehow we have to aggregate what we know all about this to make an objective decision.
Yeah.
Because none of the evidence is level 1 here. So
Correct.
we have to cook from what we have and combine all lower level evidences. So this is what I think computational method can help us to battle these cases. And you already have here 3 driver alterations, and the interaction between these 3. So it's a unique. So each patient has a unique combinations of alterations. So,
Yeah.
and we want to match therapies not to a single gene, but to a combination of genes.
Yeah.
And that's the challenge here. We have to look at the pathways absolutely, but these interact, and we have to find a sweet spot. So, of course, I don't know what's your opinion of the panel. Of course, with case of KRAS, P53, sometimes we think about also CDK inhibitors as that can be combined maybe with the other inhibitors or chemotherapy.
Yeah.
And we have seen some cases where it worked. So maybe this is something we can think about in cases of KRAS. And also often we think about combining with something with an mTOR inhibitor, like a mild one with like a metformin, that can be easily combined with other inhibitors.
I think the other question Dr. Raja was saying, do you predict that the AI will be able to do what he possibly got 10 of his PGs to spend a couple of hours?
Professor Pathak mentioned that. He used very important words. He said that a lot of interactions, pathways, and we have to cook, he said. It's like, you really have to find, and we'll come to this question in my level 4, where when we are faced with such things, we'll come to that at the 2.5, level 2.5 here. This is a CA breast patient, and she is a triple negative lady, goes through standard line of chemotherapy, advanced metastatic disease, very wildly metastatic disease, paclitaxel, no response, and then adriamycin combining chemotherapy, no response, and rapidly progressing, so we didn't know what to do. So as usual, we do some profiling, and this is what we get. We get ERBB2 mutation and PIK3CA mutation, TP53 altered, and an AR amplification. So Arun, can you help us?
So this looks like a HER2 now, because there is HER2 TKI
mutation. IHC negative, triple
IHC
negative, FISH negative. We double checked
but
on.
this could still be a HER2 because the pathway is still activated. So I think this is very important, and we can see the VAF to be pretty high of 57%. So it is an activating mutation of the HER2.
PIK3, will that work?
But there is a PIK3 which is again a resistance to any of the HER2 inhibitors. So that's again a challenge. So but looking
only
at
one
this
question, basic doubt. We'll ask Madam Nathalie also. We have a basic understanding that ERBB2, when they are mutated, they are not equal to amplifications.
No.
So therefore, they are, and this is a triple negative disease, and by definition. So I'm not very sure whether we can apply the, therapy here. We did discuss about afatinib with this patient. We did not. I'll tell you what we did. PIK3CA again is a common mutation in triple negative. Again, we were not very keen, or we didn't know But we were somehow enamored by this AR amplification, so we went for an IHC with AR, and this is positive 100% immunostaining with IHC. And so we started the patient on bicalutamide, November 23. Just look at the response. So in 3-4 months, look at the response. So this is what we did to this patient, even though we will clarify that question with Professor Natali, whether ERBB2 mutations will be okay to target. I mean, in general, can you advise us if you have something about it, actually?
Thanks so much, and also happy to hear from our genomics colleagues. I mean, as you know, HER2 insertion mutations they're definitely seen in lung cancer, and they are targetable, particularly with new HER2 targeting ADCs and other emerging agents, including TKIs, neratinib, and other things that we've tried. The relevance in breast cancer, I think, is less clear, but that likely is also targetable, and other tumor types as well. And so I think we're learning, and I guess, one of the questions I always have for our genomics colleagues is, why is a HER2 insertion not the same in lung cancer as it is in breast cancer, as it is in gastric cancer, if you see it? And, why are all the treatments, why do they all have different activity?
Maybe ADC, like, yeah.
Yeah, so you could consider an ADC.
Yeah.
I'm Canadian, so everything we do has to be proven by a randomized trial. So a lot of this is sort of beyond us, once we got past level 1. But, I certainly think that if, your patient's willing to try, it's a good idea. But maybe...
No, absolutely. So I think we kind of agree that here in ADC, trastuzumab ADC is the best choice. And it's interesting that actually not just because, of course, for 2 reasons. One is that it was shown in lung cancer that that's the best choice. It have been a lot of trials on this, but also because of the resistance mechanism caused by the PI3 kinase mutation. So again, but going back to your comment that we need randomized clinical trials to prove, so but the challenge is that we will need randomized clinical trials with breast cancer patients who have exactly the same mutation and exactly the same PI3 kinase mutation and the other mutation this patient. And we have to collect these patients and then randomize them between PI3 kinase inhibitor, HR2 inhibitor, and chemotherapy to see which is the best one. And so, and this is what I will have a slide if I get a chance to talk, that I calculated that we will need 14.4 million years to do this. So we will have a lot of conferences.
Can you just pass
Amish wants to say, Amish, just be quick. My time is also gone.
If we go back, why did you decide bicalutamide, and why not something like TDXT in the previous case, what you showed?
Point taken. That's what.
And how long did he respond or patient responded to bicalutamide? Must be short lasting.
See, this is from October to Jan 24. Just 1 week. I mean, 3-4 days ago. Look at the scans. This
okay, so it is still ongoing.
This is still ongoing.
Okay, but what was your reason of selecting bicalutamide and not attacking the allele frequency of 53?
Triple negative. We talked about ADC to them, NR2, not at all affordable. And then PIK3CA, we were not sure, single agent, not possible. We didn't know what to do. We talked about afatinib to them. And then finally, cost was a problem, and AR appealed to us, and we did this. I'm just presenting it here. Okay. We'll connect all these dots, later. We will definitely, you are also going to give a talk on. So level 3 cases. So little bit more complex. So this is a CA colon stage 4 with lymph nodes and liver mets, Dr. Nitesh patient. He tried FOLFOX and FOLFIRINOX could not be done, could not be tolerated.
So
obviously, pancreas progresses. And sorry, it's a pancreas. And these are the profile of the patient. So once again, we'll turn to, this time I'll ask Madam Prachi, your clinician comes to you. I said your clinicians come to you. So in such patients, in solid tumors, what more can you do in solid tumors from your laboratory background? This is a pancreas. Let's say this is a colon or a
Yeah.
pancreas. This is
Yeah.
actually a pancreas. 5
Well-
more minutes, Nitish.
yeah.
So
I'm using
basically,
my
I mean, if it was something where we could do the fish, and basically currently we have the HER2/neu thing, then we could do it. Otherwise, not much at present.
Not much
Yeah.
percent. I will give it to Nitesh to explain what he did with this patient.
So essentially, we asked for some opinions from a couple of molecular oncologists because this was very confusing to us. I'm just reading per verbatim what was read, and then we'll see how we applied this to science. We'll ask the panel. So could you just have the next slide, please? Yeah. So the patient had SMAD4 loss, which upregulates EGFR and ERBB2, which is maybe the reason why there's amplification. We would consider small molecule ERBB, EGFR inhibitors such as neratinib or dacotinib, combined with pertuzumab for SMAD4. It can also upregulate MEK pathway, so there would be a consideration trametinib. And finally, the MTAP causes pemetrexed sensitivity, and CDK amplification, abemaciclib. So you can see there's almost everything there. Since CDK4 pushes the cell cycle through G1S and pemetrexed stops in S phase, would choose pemetrexed with that. Our first choice would be neratinib, pertuzumab, trametinib, and start neratinib and trametinib. So what we did with this patient, which is not mentioned here, is we continued Folfox for a little bit longer. We changed to Folfirinox actually, not continued Folfox. She had severe toxicity. And they finally added Herceptin, pertuzumab with 5-FU, and she actually had a stable disease for a while. And now she's gone back to Bangladesh, and we added neratinib, which she is tolerating, and her markers are not rising at about 8 weeks. So somewhere this strategy worked, but it was very difficult to get through from across the world actually.
And this is where Professor Petak's care pathway
Yeah.
would all help. I think we are taking 5 more minutes. The organizer is given. So don't worry. So level 4. This is very simple. This is not cases. Just a quick review of. Hi, Dr. Bhavna. Literature discussion. This is an important paper. Real world evidence of how these CGPs would really be effective. This was published couple of years ago in Nature Medicine, and this was led by very profound authors, including Professor Razal Karzrock. So I just want to bring the data quickly and come to all our clinicians on what they are taking away from this. So the entire group, this is entirely from the North American continent, many of very, very illustrious people, and 715 unique patients, and in which they profiled those patients. These were the mutations in that data set. So this is some of the important outcome curves. If all the recommendations are met, this is the progression-free survival. You can see that the green curve goes on the top. And if part of the recommendations are met, it's the blue curve, little better, but not as good as the green. Same thing goes for overall survival. So they are showing an overall survival advantage if all the recommendations are met. Then they had one more interesting way of analyzing this. They called it as matching score of 50% or above. What is meant by matching score of 50%? That's where what Professor Petak mentions. If there are more than 1 alteration, 2 alterations, 4 or 8 alterations, when the definition they maintain 8 alterations. In 8 alterations, if they are able to target 4, they will call it as 50%. So it is, in other words, if it's a combined maneuvering, if you use a combined maneuvering and if your matching score is 50 above, 50 to 100%, this is the progression-free survival. If your matching maneuver is below 50%, that means if there are more than 3, 4, and then you are able to target only 1 or 2, this is what you get. And this is the overall survival if your matching score is above 50%. And this is the responses, complete remissions, if you have a matching score of more than 50. That means you are able to co-target multiple targets. So this is a real important question because single targeting and all is already you are all comfortable, but this is where. So I'm going to come to some of our experts. So quickly to Satish, what do you think? more than, like what he said, there are more, he is doing well with futibatinib, and he wants to add alpelisib to that. So there is not much literature trying to target more than 1, 2 together. So what's your comment quickly?
Sir, definitely I'll agree. We used to have previously we strong believer of single gene alteration we used to target started with the CML era. But definitely we learned the resistant mechanism is not a one drug. If you're having a drug to overcome the resistant and even older pathway is okay. But now we are seeing different pathways are coming. Definitely we should eat that. Otherwise, the way forward
How
is...
comfortable you are in
Sir,
combining more than 1, 2, 3, 4, Sai?
Sir, we had to have a dose reduction. And
No, I'm just asking. Nobody has enormous experience. Your gut feeling, that's what
I
I'm
think
just asking.
open mind and learning.
Open mind and learning, that's a great answer, Vinayak.
I agree with this combination. I think if you look in that BRAF mutation, the moment 2 drugs came, 1 + 1 was 5, not that one. So with a lesser dose, we can manage.
Can I ask a quick comment from Bhavna actually, because I think she has gathered data on the molecular board recommendation and in fact whether we followed that or not. Very quick, and then we'll have to end, I think.
So we've just got this accepted in JGO, and what we found that there was 50% discordance from the MTB recommendation to what the clinicians did. As a second level, I love the paper, Dr. Raja, that you've showed. What we need to do, Nitesh, is collect the outcome data now. Patients who got the matched therapy, but most of the matched treatments were drugs which we would, can do through IHC, HER2, MMR. So NGS, I think we also need to look at what NGS added extra, which IHC and PCR could not do. I think this is very important for our country as well.
Yeah, Dr. Bhavna, more important is this. I mean, NGS is one tool. Yes. I mean, whatever tool is available, you grab. The idea is genomic targeting. So I'm turning to Professor Petak on this question. Co-targeting, multiple targets, co-targeting. Yes. I mean, you have talked about it. So you have heard our panelists, experts. We are all still learning. So Mike, last question to you is this. When we try to do co-target, where are we in the regulatory world and where are we in the peer-to-peer acceptance world? That is what I want to ask. That's what I'm calling it as level 5. Sometimes we feel that we are alone there and we are on our own. So what is your comment?
Yes. Thank you so much. So could you just go back to one slide to that? Yes, this one. So yes, of course, there are multiple studies starting with preclinical studies that it makes sense that if you have multiple driver alterations and you have the capacity to target more than half of them, you will have a higher chance to achieve a response than compared to if you just target less than 50%. But so it makes sense. But if you look at the results, what amazes me even more that you see partial and complete remissions also in patients who receive a monotherapy or that targets less than 50%. So is this 2 glasses with waters are not just one totally empty and the other is totally full. So there is a difference, but I just want to point out that there are patients who respond to monotherapies despite of the presence of multiple genetic alterations. And that's the art, how to pick the one that works despite of the other. So if we are able to choose between registered therapies based on the molecular profile, so my response to you or answer, I think we should be able to use the totality of the molecular information to make better choices between registered therapies approved in the same indication. So we should also not just think about using this information to prescribe off-label therapy, but use the information, whatever evidence we have, to make better decisions between approved therapies.
One last question to Professor Madam Natali. this artistic world where we want to be versus regulatory world. In your advanced country, let us say, regulatory world, what is the reality? If you can just reality check on that, then we'll wrap.
So I think, unfortunately, because regulators are not on the same wavelength, the gap is growing. Things are approved based on small numbers and fantastic complex science, but then they are not funded in bigger jurisdictions, and patients can't access them. And so until we prove that the approach, and maybe we can design a better randomized trial rather than the 40 million year trial, this concept that the approach of getting the right patient to the right treatment faster is better than not. Somehow we have to convey that better, but the gap is widening, which is of concern.
I think just as my last comment, I find this whole precision medicine also helps us to, pick that patient where as you do something, they fail, you know what else to do, and sometimes prognosticate them. So it's not only about having a mutation, it's also sometimes understanding why it's failing, and then you play with it and you play with it and you play with it. I think we all have those one or two or maybe few patients where when you've done that, they've done much, like my cholangiocarcinoma. We gave GEM, he had severe toxicity, but he somehow sensitized to FGFR for another 8 months, so all those things work. Thank you.
Thank you. I must thank Nitesh for graciously allowing me to.
No, please.
Thanks all the panelists. Thank you so much.
Thank you very much, Dr. Raja, for the excellent presentation and all the cases. All your cases were excellent. The best I liked was your level 5 case. Because ultimately, it's we clinician only we have to decide. There are so much of information that we get from all over, but the patient is in front of you. You are a clinician. You have to decide what you are going to do best for the patient. And all this information comes from many, many parts. Even the radiologist gives us an information. So this is just, I would think, as one of the part of information that we get. But we have to process it. The patient is in front of you. So now we go to the next panel discussion by the moderator is Dr. Amish Vora. He is the director of Hope Oncology Clinic, Delhi, and we'll be having another interesting session. Welcome, Amish.
Can we have 3 panelists, Dr. Bhavna Sirohi, Dr. Amit Verma, and Dr. Akriti? Do we have Dr. Akriti? Yeah, there. Okay. Bhavna, please. Okay. Perfect. Okay, so I will quickly start. And Bhavna and Nitesh, you have to answer my first question. Bhavna, in the clinic, when we say triple negative breast cancer, grade 1 and key 67, 13%, suddenly you realize something is wrong here, right? Triple negative, grade 1, key 67, 13%. Similarly, reported as diffuse large B-cell lymphoma. Patient is absolutely asymptomatic. Mesentery is studded with small lesions. This is follicular lymphoma. And then suddenly you realize something is missing. That is what we see in the clinic. So Bhavna, I don't know how to read NGS. How many medical oncologists in the country, percentage-wise, actually know the way we know now biologies? Similarly, how much do we know about NGS?
So I think that's a very good question. We started doing the molecular MDTs in March 2021, and we are still learning. And what we did was, in the MDTs, the way I think if we all should do it is that we get, whatever the platform is, in India, like there are hundreds of platforms. So we get the scientist of that platform on the meeting as well. And we get a site-specific oncologist in the meeting as well. So in India, we do everything sometimes. We don't have the luxury because we are so short of medical oncologists in the country. So we don't have the luxury to be site-specific. We can't be. To have a site-specific oncologist, have a molecular oncologist, germline geneticist, Aparna is there,
She's always there. So what they do is they go through the report before, and sometimes a report has been called as a VUS, and they come back and tell me, actually, it's not a VUS. So, having that expertise is very, very, because we can't do everything as
Bhavna,
medical
what
oncologists.
percentage of us know to read NGS? That is my question, simple question.
Very few of us.
Very few of us.
Yeah.
Nitesh? Very few. You are so close to reality because, I remember once I was called in Bangladesh. I was giving 3 hours talk of NGS. I think I knew 0.001% of what I was talking, and I was teaching others what is about NGS. It is not fair, I think. Whether to say NGS helps us, NGS works, I think first we need to understand the biology of it. Amit, you have been on the, you are the molecular biologist. My one phone call a week goes to you always. To understand, still I don't understand. How many of us medical oncologists genuinely understand the interplay of the 5 different mutations which a foundation one gives very nicely on a nice piece of paper? So you can be open. Nitesh said close to 0, and I agree with him.
All my friends are very savvy to all these things, so everybody is 100%. The one who calls me, he knows about the science. Yeah.
Akriti, would you dare to answer that? How many of us really know NGS?
So I agree with Dr. Nitesh, and we are all learning on the way, actually. We still have to go back to the literature, see all the resistance mechanisms, what are the crosstalks, and then probably...
Right. So, what Dr. T. Raja was showing, and I think Amit has been showing that for last many, 1-2 years, matching of 50 to 100%, less than 50%. I don't have, right now, do we have the courage to give 4 targeted drugs altogether? That is the bottom line, I think. Till the time we don't reach there, I don't think we can say that NGS is helpful in 6% of patients or 10% of patients. That is what I wanted to highlight. So let's come to some 2-3 cases quickly. So this is a 59-year-old female, no comorbidities. She had CA breast, sister had CA pancreas, died within 1 year of diagnosis. Sister. This patient had IDC, LABC, ERPR positive, HER2 negative, MRM done in 2017, 20 out of 22 lymph nodes positive, chemo, RT, letrozole given. 2019, and Nitesh has seen this patient, 2019 relapsed in vertebrae, liver, and there was a skull bone mets also. So, SBRT given to painful mets, and fulvestrant and palbociclib was started. At the same time, since it was 2019, routine NGS had started. It was done in this patient, and that was from liver biopsy, in which I will come. So, after 3 months of fulvestrant and palbociclib, in fact, there was non-responsive, and there were 3 more liver lesions which popped up within 3 months of starting fulvestrant and ribociclib. I'll just come to NGS again. Based on NGS data, we started nab-paclitaxel, responded very well. But 14 months later, actually, this was the only period when the patient responded to the treatment. Patient developed carboplatin hypersensitivity, which we normally see after a lot of time on carboplatin. Severe bronchospasm, carboplatin was stopped, nab-paclitaxel alone was given. But again, there was progression in the disease. Okay. So this was 2020 NGS, and let me start with Akriti. Just based on this history, help us understand, can we do something about it? Patient and relatives had taken multiple opinions, and they were desperate to start alpelisib. Nitesh को call करके कहीं से उन्होंने alpelisib ले भी ली थी, जेब में रखी हुई थी, and they were waiting to start.
Sometimes we only see the genomic findings on the first page, and we kind of jump on the targeted treatment. But we tend to forget that there may be some other mutations which were showing resistance to the target. And that is why maybe, we missed that, and maybe that was a VUS, but that had a crosstalk.
Okay, CA breast, ERPR positive, 2 lines of treatment done, and PIK3CA, is it unusual? I feel this is the most usual report. Amit is nodding his head. Amit?
Yeah, I think so. What is usual about the case that we saw the PIK3CA alteration? But what is unusual that we saw another double hit in PIK3CA, so which we don't normally see. So what is the implication of this double hit in PIK3CA? It is something what you call a trans kind of a thing, or a cis kind of a thing we don't know about. And if I use a PIK3 alpha inhibitor, am I going to address the rare alteration or not? I don't know about.
Okay.
So these are the couple of questions what I have in my mind before I jump to the treatment decision on this case. But
So
I can say for
in
sure.
this particular patient, alpelisib is the right choice?
Maybe, but I would say if I'm not sure about it, then I go downstream. I prefer mTOR inhibitor if I'm not sure about it. But a small short stint of a trial of alpelisib is I would try to go first actually.
Bhavna, you are a clinician. Alpelisib is approved with fulvestrant basically, and fulvestrant failed in this particular patient. So I have two questions for you. One, 2 years of letrozole and patient progressed. Just close to between primary and secondary hormone resistance, what we call. And patient did not respond to fulvestrant and palbociclib. Would you give alpelisib in this patient? Say Amit recommendation is a short trial of alpelisib. Would you give monotherapy or would you combine with something?
So just a quick question. Was the liver biopsied for?
There's a liver biopsy, yeah.
So it was HER2 negative?
No, this foundation report is liver biopsy.
Yes. Achha, it's a liquid biopsy. So
liquid biopsy, yeah.
I would give alpelisib actually with endocrine treatment, probably tamoxifen.
You'll give tamoxifen.
Because she's progressed on fulvestrant.
She has progressed on letrozole within
and
2 years. Within 2 years and 4 months of fulvestrant and palbociclib, she didn't respond. Why would you
So
offer
I would actually,
tamoxifen?
giving an AI is also not a bad idea because she had 2 years on it. So you could give exemestane. But I would combine it with endocrine therapy because, giving alpelisib alone, I wouldn't.
You wouldn't.
One question I have for Amit, the people who have double hit, are they super responders? Not necessarily. We don't know about it. Okay.
Raja sir, patient in your clinic, 2 years letrozole failed. 4 months of fulvestrant palbociclib failed. Would you give the third line hormone, although 14 months have passed since patient has received hormonal treatment? But patient did not respond to either of the hormonal treatment what we gave. Would you give third line hormone in this patient?
Clinical. I mean, if the patient is, clinically okay, I would still be keen to look at, as Amit pointed out, what catches the eye is the double header there. But again, as he pointed out, there is no data to say that it should not work here. And I don't think I can deny this patient an alpha inhibitor. I mean, we know that the other pan inhibitors of PIK3CA are not clinically well established. They are very toxic. So I would take his advice, and I will be still thinking about alpelisib. I will be still be continuing one of the endocrine backbone. Fulvestrant and alpelisib is the well-approved one. So I'll continue that, and I'll be quickly looking for, like what is said, add a downstream, if possible, everolimus, toxicity and all be titrated. That's how if the patient quickly progresses, I will then throw in, something else.
Something else,
yes.
right.
That's how I will decide.
I actually would use AI with alpelisib.
AI with alpelisib. So this patient, of course, Amit also said short trial of alpelisib. Patient could not tolerate. Within 1 month had urosepsis, and 2nd month patient had diabetic ketoacidosis. Patient refused to take further alpelisib, and we said, okay, we decided. And there was, liver was studded with metastasis at that point of time. Now the question is, why this poor response to hormone? And the answer, what we got in this NGS report, Amit or Akriti, does this report tell us why this patient did not respond to CDK4/6 inhibitor and fulvestrant?
So the first question, why I did not respond to CDK4, we have the answer setting RB1 loss.
Right.
Which can clearly answer why it did not work. But, and the other question was fulvestrant. Amish?
Yes.
So the fulvestrant didn't work because we have the PIK3CA, even Richter amplification, the same pathway. We have a parallel pathway that is MAP2 kinase. We have again PIK3C2B. So PIK3CA and 2B. So there are two parallel things which are happening. So That is the reason why alpelisib did not work. So
Amish,
we were
Amish,
targeting
this is
only
very clearly endocrine resistant,
Yes.
multiple endocrine resistant.
Yeah.
This patient is a classical candidate for AKT inhibitors. So
Sir,
that's what we
if this patient, before starting CDK4/6 inhibitor, if you have this report,
we have talked about that. If the patient has been completely naive of CDK, and then I see a profile like this, that warns me that this patient is going to be very, very resistant. Let's say an ESR1 is there and everything. But still, it is advised that we should start CDK4/6 inhibitor, accept that few months of control, and then keep looking for this. And these are the patients who are heading towards the AKT inhibitors, if we can get them.
so you are so right, sir, because even though we know that this patient is not going to respond, there is no literature support which tells me that I cannot give CDK4/6 in this patient.
And also, Amish, what it does, as sir is saying, it gives you a couple of months of control. Right? We do chemotherapy for 6 months control. So these patients develop early resistance rather than no response. So that's the difference.
So Amit, if along with CDK4/6, if you would have added alpelisib in this patient, would it have reversed CDK4/6 resistance?
So I said that there is a PIK3CB also. Alpelisib is not the right choice.
Not
If
going
you
to.
ask me CDK4 with everolimus, maybe
With
yes.
everolimus.
Maybe
So
yes.
the combination, Nitesh, if Amit says that, okay, fulvestrant, CDK4/6, very good, but add everolimus. Would you add everolimus in your clinical practice?
After the urosepsis and diabetic ketoacidosis?
No, forget about that. This is a story. What I'm saying, patient is still naive to alpelisib. That is what I'm saying.
I'm very reluctant. I have breast cancer. I would rather use chemotherapy any day.
So you would use chemotherapy.
And this
Okay.
patient had a very good response, and the multiple lines
Bhavna,
left.
would you add everolimus as suggest? Would you add everolimus to CDK4/6 upfront in this patient?
No, I would not.
You
And
would
in
not.
fact, the trials that are done, we have NGS report is fine, but there's survival benefit seen with CDK4/6 inhibitor and endocrine therapy. So I would go with standard.
Go with standard treatment. Okay. So that is where we are. Even though we know this NGS, but we as a clinician still are reluctant to add that. Fair enough. So TP53, we will not ask the question. Let's move to next question. We have 6.5 minutes. So because I was given the rare cancers also, so I thought I have to give one rare cancer. So this was one of the, I have not exact patients, but similar WhatsApp image one day I got, कि Dr. Vora, 56-year-old female, इसका क्या करना है? So I said, we need to work up. So large upper neck mass, MRI face and neck, there was a large parotid swelling. Biopsy with immunohistochemistry was c-KIT negative adenoid cystic carcinoma. So final diagnosis was stage 4 adenoid cystic carcinoma. Since c-KIT was negative, we offered chemotherapy to patient. After 4 cycles, PET-CT showed progressive disease. This is classical what happens. So Bhavna, in adenoid cystic carcinoma or any rare cancer, role of NGS comes when,
So I would do it upfront, especially in carcinoma of unknown primary. This is one area where if finances are not an issue, or sometimes I call my friends across the country and try and get them to do it for free also. So here I would do it because, it may help us with the decision-making process.
Amit?
I think once we hit the rare cancer, we should straight away go ahead with the NGS.
NGS upfront, okay.
Upfront, yeah. So
Akriti,
don't wait for the refractory.
Akriti, if c-KIT is positive, would you advise NGS upfront in this patient? They are c-KIT negative, but if it is positive, is there a role of NGS upfront in this patient?
So NGS, like we said, it's unknown primary, so it should be done because there may be something
No,
else.
this is adenoid cystic carcinoma of a salivary gland proven. This is not unknown primary. This is a rare cancer.
Yeah, it's rare cancer. It should be done.
It should be done upfront. Nitesh, is there a
Also,
role of
one more thing.
NGS c-KIT positive adenoid cystic carcinoma?
I would say yes, actually, if costs are not concerned, because you want to look for other things, because these patients don't respond to so many therapies. So you want to know everything upfront, and you're likely to find nothing actually.
One more point I'd like to add. It should be done from, if the cost is not a concern, then probably an FDA or a CAP approved lab. Because then we tend to miss out on things. And we come to standstill that, we're not sure of the quality of the report. So that should not be compromised.
Okay. So one of the title of the talk was NGS opens up the gates. That is what Nitesh had written. And this is the gate which adenoid cystic carcinoma can open up if you have different mutations. I think almost all mutations are targetable here. Okay, and one of the most common, the Amit, adenoid cystic carcinoma, NGS, which of these are common, or you see almost all of them? Because this is what the literature reports.
Okay, so regarding the c-kit, what you are mentioning, it is the expression, not the mutation, what we are talking about. It may not work even if we have the c-kit overexpression.
So you would do NGS upfront. Okay.
Yeah, so
okay.
that's not
Point very well taken. That is what we wanted to tell people. So this MYB protein basically is the most common mutation which has been described in adenoid cystic carcinoma. One of the, so we say here EGFR. EGFR, if you see, the patients have been given chemotherapy with cetuximab. And if you see, in this particular paper, December 13, 2023, just recent 2 months back, there was a overall responses, 3 with complete response, 2 with partial response, 1 with stable disease, and only 1 with progressive disease. So it is a very small study, 8 patients data, but out of 8, 7 patients responded to the targeted treatment in adenoid cystic carcinoma. And if you see another one where you had targeted, as I said here, MYB protein, ATRA works there. So ATRA with apatinib, the disease control rate of 100%. When do we see 100% disease control rate in anything? All those small studies, but what I'm trying to say is that in these patients, sometimes the gates are opened by NGS, and we should keep our minds and ear open and use NGS rather than using expensive medicines upfront. There's a last case for today, again a rare cancer. Yes, Amit.
Just to add to the last case, I would like to share one quick experience. We had a BAP1 mutation in adenoid cystic carcinoma, and we gave PARP inhibitor, and the patient is doing fine actually. So just to share.
Absolutely, right. So this is another case we see now commonly. I don't know why we see. I never saw so many of anal canal cancers during my DM days, but I'm seeing lately quite a few. This is a stage 4 CA anal canal, lung, liver mets, squamous cell carcinoma, classical. Again, this is what the NCCN guideline says about giving first line, second line, and subsequent treatment. Bhavna, would you do NGS? Anal canal again comes under rare cancers.
Yeah, but I agree with you. We are seeing quite a lot of squamous anal cells. So my experience with squams has not been very good with NGS in finding anything actually. 5-FU cisplatin still remains the standard of care, but yes, they will progress. So I would do NGS just in case we find something. But my experience has not been very good.
Not been very good. Amit?
Just to add, we have the immunotherapy option in these cases. So NGS may help that who are the patients which may not respond to immunotherapy. That is the only thing that I will be looking at.
So there are 2 case reports which I have taken from ESCO Pub. They have given 11 cases. I think again last year, 2023, January 2023, this has come, Journal of Clinical Oncology. So these are the 2 mutations. Basically, they wanted to see concordance between serum and the tissue. But if you see the somatic mutations in the first patient, CDKN2A, TP53, and CCND1, Amit, patient has failed on FOLFOX. What would you give? What would advise you give to us?
First case?
Yes.
CDKN2 and CDK1?
Yeah.
A CDK4/6 inhibitor can be an option if you want to try something outside the box. Yeah.
Okay. Akriti, about the second case, MAPK1, 15%. That is somatic.
So I would not like to comment on the treatment per se, but like we discussed that immunotherapy can be an option. So maybe doing an NGS there could help us know the immunotherapy markers.
Amit?
So I can see the MAP kinase, the FANCONE-CA, the FANC-A actually, and the MSH2. I would like to know whether the patient had MSI high or not. That will be my next question. And if not, then definitely a possibility of MEK inhibitor can be attempted. And if I want to really go beyond, then MEC with PARP inhibitor will be the choice in this case.
Will be the choice. MAP with PARP inhibitor. Again, Bhavna, would you give that in your clinic? Amit, you have called Amit.
So no, our MDT would actually say no.
So, my point is that we are sandwiched. All these three cases, point was, we offer NGS so routinely to our patients, but we don't follow, or somehow we are reluctant to follow the advice of Molecular Tumor Board. Like you said, you are publishing a paper, more than 50% of the times, clinicians didn't agree. Like, if Amit tells me 4 different tablets to be added, I said either Amit has gone mad or I have gone mad. That is where we are. So I think unless and until we keep trying, and as Bhavna, you said that we keep collecting the data of these responses, we are going to be sandwiched right now. We are in the interzone. Yes, Bhavna?
So just
last comment and then we close
Just
this.
a quick thing, we must not forget to do the common things like, doing PDL1, MSI on
Absolutely.
IHC, which is simple IHC can do.
Yeah, absolutely. Amit, last comment, and then we wind up.
I think definitely there is some reluctance to begin with when you combine therapies. Either you can wait for the first, second, third line failure and then you can try. But I think sharing the experience is going to build the confidence, that is all. Dr. Raja might have a experience in combining or the rare, maybe others may not have. So those confidence, even a surgeon, when a senior surgeon is sitting on the back, when the primary surgeon is doing surgery, and they say, please push, please go ahead, that is the confidence the other gives to the others.
Dr. Raja, how many molecular targeted you have combined? 1, 2, 3, 4? No. What I'm saying, together in a single patient, say, for example, if Amit says that, you give this tablet with this tablet and half a dose of PARP inhibitor, and you give 2.5 mg of everolimus, and then you can add this tablet, would you do that in your practice?
It's just anecdotal. I think we have graduated from confidently doing single targets to confidently doing 2.
2. I agree.
Beyond 2,
not
we are looking at that window. But I want to say one thing, that this is like this whole precision medicine has put the patient care back to the clinician. Pardon me to say that. Straitjacketing with guidelines, we learn that they can help to some extent beyond a point you are in a data-free zone or a no-man territory. That's where the clinician and a single patient one-to-one comes. I think everybody is learning.
Everybody is learning. I think that is an important point. Thank you so much. Thank you all the panelists for your time. Thank you.
All right, thank you, Dr. Vora and panelists. We'll move on to our next speaker, Dr. Natasha Leal. She will be speaking on liquid is solid in advanced NSCLC. Dr. Leal is a professor of medicine, lung site lead from Princess Margaret Cancer Center, Toronto.
Great, thank you so much. It's a real pleasure to be here. Let me see if I can get my slides. Here you go. All right. So I'm delighted to be here. This isn't my first time in Bangalore, but every time it seems as though the city is even more beautiful. So delighted to be here again. I want to thank Dr. Natasha and the team. So I've been given this challenging title saying that liquid is solid in advanced non-small cell lung cancer, and I really think it's become an extraordinary tool for our patients, not just in lung cancer, but in all advanced cancers, as we heard in the last session. And, it's been a very interesting time. I mostly focus on lung cancer, and we've started to see that even though we're not really curing more patients with lung cancer, we're improving outcomes really through molecular diagnosis and more targeted therapy, with 5-year survival rates now of up to 30%, even in Asia, in Japan. And of course, here in India, this group here is leading the way, working very hard to improve outcomes, despite the fact that you are seeing more women with lung cancer than ever before, and many more never smokers. All the more reason to double down and promote molecular diagnosis and targeted therapy to improve outcomes.
And certainly over the last 5 to 6 years, you know that it's gotten much harder to treat all of the cancers, and certainly the number of targetable biomarkers in lung cancer has more than doubled, with over 24 targeted therapies approved even in the last 5 years. As you can see here, this is the current state of the art if you can find the target and then treat it. And we've learned that even in Asia, up to 70% of our patients can benefit from a targeted molecular approach. So we heard some very nice data earlier looking at comprehensive genomic profiling instead of single gene testing. And this is a very interesting series that's been published looking at 120 patients from here in India and plasma testing. And what was very interesting, and I think one of the things that we all love about plasma testing with a very reliable, sensitive assay, is the quick turnaround time, less than 7 days. The fact that with a very sensitive assay, most of our patients actually get complete genotyping, over 90% in this series, and not dissimilar to other places, they were able to find actionable targets in 50% of patients. And if you look at the bottom left at what those targets are, it's not all EGFR and ALK, although that's many of them. Another 21% of patients had other alterations beyond single gene testing. So again, I think it's incredibly important. Also, for those patients with EGFR alterations, a lot of them were uncommon or within exon 20. Of course, I think a very important population here in India. So this is just a case where we look at PCR versus NGS, and in particular plasma NGS. This is one of my patients. She actually became mine during the pandemic. She came from China. She's had lung cancer now for almost 8 years. She had surgery initially, adjuvant chemotherapy. She recurred. They tested for EGFR in tissue in China using PCR. And when she was negative, they gave her chemotherapy again. And what's interesting, she then came to Canada. She was sent to me for an immunotherapy study. We put her on the study, and her disease it's been indolent. It's not been rapid, but it's progressively grown. She's never responded to either chemotherapy or immunotherapy. So when she finally progressed and we took her off trial, I had some residents in our clinic. And of course, the question was, Asian woman, adenocarcinoma, lifetime never smoker, do we really believe that she's EGFR negative? And so should we biopsy? She explained to me in Mandarin we were not going to do another biopsy, but she was willing to have a plasma test. And lo and behold, she had an EGFR exon 20 insertion. And with that, we put her on her next trial. She was actually one of the longest running patients on the Chrysalis study. I think she's the second last person to come off. She just came off after 3 years of amivantamab. Dramatic response, tolerated it well. Her 4-year cough went away, and we've actually just rolled her onto a new study of a new kinase inhibitor, and she's responded again. So just with a simple blood test, we've been able to get her at least another 3+ years in this lung cancer journey. So an incredibly powerful tool. And of course, we know that NGS does detect more alterations than many PCR tests. EGFR exon 20 is a very easy example. Most of the PCR kits that we use find about 4 of the most common alterations, but you can double the number of exon 20 insertion cases that you can find just by doing NGS. And of course, all of these patients are potential candidates for these novel exon 20 inhibitors. Even when we look at other alterations or sensitizing alterations, NGS is still a little more sensitive than many of the PCR assays, which I think, has, whenever we can afford it, moved most of us to NGS first. In lung cancer, tissue has always been an issue. Anywhere from 1/3 to 40% of our patients just don't have enough tissue for NGS. And this is from a nice study from Dr. Charu Agarwal, where they looked at 2 years of their patients with advanced non-squamous lung cancer, and they found that if they looked at tissue, only 24% of patients overall in their entire experience had complete genotyping based on tissue in the blue bar, 20% in time for first-line therapy. And just by adding plasma testing, she was able to quadruple that and get it up to 76% over the patient's entire journey, and 80% of patients were able to get complete genotyping with plasma testing, really showing that this is an incredibly important tool. She also looked at long-term outcomes, and I think what surprised us all on the left here was that patients who had complete genotyping before starting therapy had a dramatically better survival. I think most of us would be very compelled to give any patient the drug that's associated with the survival curve on the left there, but it's actually just complete genotyping. And so, of course, a lot of that is finding the target and getting them on the right treatment. Some of it also is prognostic. And so, some of this is selection bias, but still incredibly powerful just from making sure that you get the right test for your treatment. Even later on, if we miss our first chance, there's some data from the INFORM database of plasma testing in the US suggesting that patients in blue, where you find the target and you get targeted therapy, do much better than patients in red, where we found the target, but they never access treatment. So never too late to make the right diagnosis, although earlier is definitely better. So at the IASLC, we updated our consensus on the use of plasma testing. And certainly tissue biopsy is still essential for diagnosis and for PD-L1 testing, but clearly repeat biopsies are a challenge in our patients. They take longer, and they don't really reflect the heterogeneity of the tumor that we're learning more and more about. In terms of genotyping, plasma can be equivalent to tissue testing. It's highly concordant, tends to be much faster in terms of turnaround, and of course is much easier and is able to reflect the heterogeneity that we see across metastatic sites. Now, one of the challenges, of course, is that it's much harder to detect cell-free DNA than it is to detect tumor DNA once you do your microdissection from your slide. And so, you need a sensitive assay. You also need an assay that can pick up fusion events and copy number events. And so very important to remember that if you don't find those, reflexing to tissue is always very, very important. So what do the guidelines say? And I think currently there's been a real trend towards recommending ctDNA assays. It's been recommended by ESMO, the NCCN, the IASLC, ASCO, and a recent Asian consensus which has been published, including India, of course, that validated assays that are sensitive can be used for genotyping as well as tissue. And this actually goes beyond lung cancer, of course, although it's highly recommended in patients that are about to start first-line therapy, those patients where tissue is unavailable or rapid results are needed. And in fact, the NCCN has updated their guidelines to really recommend strong consideration of doing both tissue and liquid, or at least integrating liquid whenever possible. Now, we do know that TKI resistance really was where liquid biopsy started for us, looking at T790M after first and second generation kinase inhibitors. But even now, with better agents being used in the frontline setting, the guidelines haven't changed. And plasma testing is still recommended, although I think the role of tissue is also something that we talk about in clinic. And I think across all the guidelines, if you don't find something in plasma, you should look in tissue. But certainly if you find something in plasma and you're using a validated assay, it's enough to start your patient on treatment, not yet ready for prime time in terms of MRD or treatment monitoring. So my first study that I did with liquid biopsy, I was very lucky. We were the only Canadian site on the Nile study where we looked at the clinical utility of plasma testing in patients with advanced lung cancer. Everyone had to have lung adenocarcinoma. We accrued over 300 patients and we had 282 eligible, and we compared the outcome of tissue testing with plasma testing, and in this study we used the Guardant 360 assay to find the 8 actionable targets recommended by the NCCN at that time. And to our surprise, in the top left in orange, we found that more patients had a target found through the blood test than they did through the tissue test. And of course, the optimal scenario or optimal detection was when you use them both together. And so there's this concept that there are some patients where you find it in tissue or in plasma, some where it's just in tissue, and some where it's just in plasma, really suggesting the complementarity of this approach. Because plasma did so well in this study, it was clear that if we started with a plasma-first approach, that we might be able to fast-track things in terms of finding an actionable alteration with much faster turnaround time, about a week compared to 2 weeks, and a much higher rate of complete genotyping. So in our study, 95% of patients with the liquid biopsy had complete information available, as opposed to only 30% with tissue. And this has been repeated in several studies now of nearly 2,000 patients. We then went to look at outcomes on treatment, a much smaller number here, but we did collect RESIST data on a subgroup of our patients getting targeted therapy, and what we found was the same high response rates that we see with tissue-based testing. 100% response in our patients with ALK and ROS1 driven tumors, and over 50% for our EGFR mutant lung cancer patients, with an overall response rate in the cohort of almost 60%. So again, whether you find it in plasma or in tissue, it is solid. Of course, how you put it into practice is another question. And, I think there's a sequential approach where you do tissue first. When it fails, then you look at plasma. But of course, that takes a lot of time, and lung cancer patients don't have a lot of time. There's a plasma first approach where you already know the tissue won't be successful. And of course, it's really important to remember that if you don't find something in plasma, you really have to double down and reflex to tissue. And an emerging approach, which is, I think, becoming very popular, especially in North America, and I suspect also here, is complementary, or doing both at the same time. Now, the great thing about that is you're very likely to get the right result and faster. The challenging thing, of course, is it doubles your testing cost. So we had such a great experience on the Nile study. So many of our patients were rescued with plasma testing and were able to start targeted therapy that we wanted it funded in the Canadian cancer system for all of our patients. So my colleagues and I in Canada developed a study called VALUE, where we looked at plasma and tissue testing at the same time in a selected group of patients, advanced non-squamous lung cancer patients with a light or never smoking history. Everyone had to have a diagnosis. They got their liquid biopsy, we looked at quality of life, we got the results, we looked at treatment that they got, and clinical outcomes, as well as cost and system outcomes. And what we found, as you would expect, is that it only took a week to get the plasma NGS results, as opposed to 3 weeks to get tissue results. Also, we were much more likely to find a target if we used plasma and tissue. We found that in 68% of patients, compared to 53% of patients if we used tissue alone, remembering that this is a selected group of patients. Whether we found the alteration in tissue or in plasma, tissue response rates are shown in green, plasma in blue, the outcomes were really the same. So again, you get the same information from either one. And if you got your patient on targeted therapy, they had better progression-free survival, and of course you were much more likely to get targeted therapy if you added plasma into the mix. We of course looked at cost, very important in the Canadian public healthcare system, and this is where we actually hit one of our first surprises. As expected, we doubled the testing cost, but you can see that that really is a drop in the bucket compared to the very large costs of testing. And by getting more people on targeted therapy, we were actually able to avoid more costly chemoimmunotherapy, which of course would work less well in our patients with oncogenic targets. And so again, I think that really brought home the concept that not only is getting your patient to the right treatment at the right time good medicine, it actually makes good economic sense as well. The last thing that we looked at was the impact on quality of life. And when we made the decision based on plasma or plasma and tissue, patients had much better quality of life, with bars going to the right, than those patients where we didn't find something and they went on chemotherapy. So, there have been studies now. I've got about 2,400 patients represented on these slides. There are probably now well over 3,500 patients around the world with lung cancer, where we looked at both tissue and plasma testing at the same time. In blue, where the results are concordant, so the vast majority. In orange, where tissue gave us the answer and plasma did not. But in green, the number of patients rescued by the fact that we did plasma and tissue together. And so again, an incredibly powerful tool in everyday clinic for everyday patients. In Canada, time is of the essence. Everything seems to take a very long time. I think it's because it's so cold. We move very slowly there. But whether it was Canada or the UK or the Nile study, liquid biopsy results were consistently much faster. 9 days versus 15. By the end of the Nile study, we got results down to a 7-day turnaround time, 7 days versus 3 weeks in our value study in Canada, and in Sanjay Papat's UK study, where he also looked at something similar, 8 days versus 22. And of course, that has a knock-on effect. Patients are then able to get on treatment much faster. Time to treatment cut in half in the Nile study and also in the UK study. And these are, of course, very meaningful for all of our advanced lung cancer patients. So what does that mean here in India? And this is a wonderful survey. I know some of you may be authors, many of you responded. This is published by Dr. Parekh and colleagues, where over 350 oncologists, mostly from India, talked about which molecular tests they ordered and their treatment practices. 2% order no molecular testing, 7% order only EGFR, just over 75% order EGFR and ALK, either together or in sequence, and only 14% reported ordering NGS. Hopefully that's higher now a few years later. And when oncologists were asked, do you wait for the test results, which is recommended by the Asia consensus, only 26% of them said yes. Most of them said they would start chemotherapy. Patients are sick. Patients can be demanding. You know, they've come to see you. They want to start now. And there's always the concern about patient attrition. But about half of oncologists would then switch based on the results. And, you know, I think it's very interesting, you know, in Canada, the government always says to us, do we have to do it now or can we wait and pay for it later? And, you know, I'm reminded that in lung cancer, it's a very fast train. And so, of course, we lose at least 50% of patients after first-line therapy. So many of our patients don't get a second chance. And as immunotherapy increases in use here in India, as it is now in North America and Europe, we're seeing dramatic toxicity when our patients switch from immunotherapy to targeted therapy. Severe toxicity with osimertinib, sotorasib, which you've heard about, ALK inhibitors. I actually had a patient who went into hepatic failure but luckily recovered. She had ROS1 positive disease and MET TKIs. And so I think the inappropriate use of immunotherapy because we don't go that extra mile to find the target is potentially very dangerous, not just financially, but also for our patients' health. And what about using plasma over time to detect resistance earlier, to diagnose molecular resistance? And I think, you know, that's very popular for many of us. In the old days, it was very easy. With EGFR, you just look for T790M, and plasma first was so easy. In Canada, we avoided 60% of biopsies, and we actually saved the government money. But now with osimertinib and these other newer agents, it's complicated. We see small cell transformation, we see complex genomic alterations, but still most of our patients do have molecularly driven alterations. And so 15% with MET amplification, that's certainly one of the earliest, and a number of our patients with on-target EGFR alterations. And so certainly plasma first can still be used as an initial triage test, and if you don't find something, you can subject your patient to the toxicity of a biopsy. And this is a nice case. It's a little older now, but it's from Nir Peled and his team. And he had a patient with an exon 19 deletion. They were on gefitinib for a year. He did a plasma test because he was worried about the patient. They developed a T790M clone found in blood. Very quickly, you know, the patient didn't respond. He did another liquid biopsy. He found a G724S, so he added afatinib with some preclinical data to support that. Patient had a very nice response, progressed again with a 797S, and this time he put them on pemetrexed. And so you can see that over a year, he was actually able to make molecularly driven treatment decisions very quickly. And of course, none of our patients would let us do that many biopsies of their tumor, can really only achieve this kind of precision medicine with liquid biopsy. Also very relevant for our ALK patients, certainly with crizotinib, we know that it's very easy to find. This is a case of one of my colleagues where after crizotinib, he found 2 resistance mutations and the potential, for example, to use alectinib or brigatinib to overcome resistance. Even with alectinib or brigatinib, you know, with the emergence of G1202R, you could add lorlatinib, or perhaps if they don't have it, maybe chemotherapy is the best answer. So again, the potential to really guide treatment using plasma. So just a few take-home points. You know, I think it's an incredibly important tool to make sure that all of our patients get to the right treatment at the right time. We've learned that it can really help us start treatment faster and help our patients avoid costly and painful repeat biopsies. Doing the two together is not only feasible, but it significantly increases our chance of finding the target and getting our patients to the right treatment at the right time, and it's now recommended by NCCN guidelines. Comprehensive testing before starting treatment also has a very powerful prognostic effect. These patients live 4 times longer than patients who don't have complete genotyping. Again, another really good reason to make sure that your patient has testing in time. And I think with all of these great data that we've seen emerging, you know, certainly liquid biopsy has now become a routine part of my practice. The Canadian government is about to roll out funding across the country for liquid biopsy in patients with advanced lung cancer. And so I think it's an incredibly important tool, both in routine practice and when tissue or time for testing is limited. Thank you so much.
Natasha, can I ask a quick question? So first of all, congrats for precisely finishing precision medicine in time.
Thank you.
You did speak about the immunotherapy toxicity, but there's also immunotherapy lack of efficacy in targeted patients. Now, one of the challenges we face is that there are targets which either don't have treatment or we can't get treatment. So what about lack of efficacy of immunotherapy in those targets?
Thank you. So, I think, and I'm sure that you do this in your practice, when we're looking at the oncogenic targets, I think there are those sort of, not immune desert, but the non-immune engaging tumors. So ALK-driven, ROS1, RET, EGFR, I think these are all a group where even if they are inflamed or you see high PD-L1, they're going to need something else, T-cell engagers, something different if we're going to use immunotherapy. Checkpoint inhibitors aren't going to work. I think for MET, KRAS, BRAF, these are a different group, and particularly in that group, I look at smoking, and then whether or not, based on smoking status, PD-L1, and some other factors, that might be helpful. And so, there's sort of the definite non-responders where we just use chemotherapy. Like if they have stage 3, we don't give durvalumab. If they're going to get surgery, we don't give adjuvant IO. But then there's also that sort of waffly group, right? The KRAS, the MET.
So that's exactly where the problem is. So for example, RET, we do not have a RET inhibitor in the country yet. We're going to get soon. Now, if you get a RET patient, and interestingly now because we are doing some of these in the early lung cancer setting, you're seeing that trend also. And immunotherapy has done wonders in the early lung cancer setting. So if you get a mutation for which you're not going to have a target, or you're not going to treat, even if you have a target, would you use immunotherapy or rely on chemotherapy alone in that kind of patient? That's the question I'm trying to get at.
It's a great question. And so I'm going to give you 2 examples because I think the real answer is we don't know, but I think most of us believe that immunotherapy is not worth it. So I have a physician that I treat. He runs the disability program in Canada, and he's never taken a day off work, even though he has advanced lung cancer. He never had enough tissue for more than EGFR and ALK and PD-L1. He was on chemo for 2 years. He was on nivolumab, no response, but did well for, I think, 4 years now. Finally, he progressed. He and I agreed, let's do a liquid biopsy, RET fusion. So he's going to go on targeted therapy, but he did have this very long history. He didn't respond, but he didn't progress either. So, did this benefit or not? Then I have a doctor's wife. It's always the wives. She had chemoradiation. She had a RET fusion. I said, I don't think durvalumab will help you. The doctor explained to me that, this was business and we were going to do the durvalumab. So I've admitted her 4 times with pneumonitis. We keep going back. I know it's not going to prolong her survival, but these are the challenges, right? So you have to discuss, you have to inform, you have to tell them what you believe, but what the evidence does or doesn't support. And then you and the patient have to go forward hand in hand. So it's a real challenge. Roche does have a study looking at pralsetinib as consolidation in stage 3. I think that the Lilly team, of course, is moving into the preoperative and adjuvant space. And so hopefully we will have data soon. But I agree with you. It's a conversation, document, and hope for the best.
Fortunately, we have the knowledge that immunotherapy and these driver mutations, it's not the same. I mean, some of them are going to be absolutely not responding to immunotherapy, say the ALK and the 19 deletions, versus some of them are still going to show some kind of response if you have a KRAS or even if an exon 20 insertion in EGFR. So it is not a single answer. So sometimes immunotherapy can still work in some patients who have a certain driver mutation. This questions about RET is also, RET is so good that it works as good in first line, second line, whenever it's so these are the ways clinically you make your answers. I have a basic question to you. When you do these plasma biopsies or liquid biopsies, there must be so much of DNA floating around normally, and also apart from that, RNAs, and now we know this microsomal RNA, everything. How do you filter out, and do you use some sort of a, for want of knowledge, flow cytometry idea, how do you pick up that relevant, and then you try to prepare your library, and then how do you do that actually?
Thanks. So, I mean, I think as a clinician, a fellow clinician, for me, it's always been a black box, but it's clear that different assays use different methods. And so I think what's so essential, so for example, the studies we did, we're using Guardant 360, so they have a great bioinformatics platforms using the TCGA. They know cancer-associated variants. They filter out common clonal hematopoiesis-generated variants. Other people, if we were doing it in-house, will use leukocytes, or, we'll use the Buffy coat as a control and subtract out. And also if you're using tumor-informed assays where you have the tumor and you can sequence the variants and then say, okay, these sort of non-classical variants are tumor-associated versus not, but of course that's a lot more work. And so I find that these bioinformatic-generated programs are much more helpful, or using AI. It's interesting, in Canada, we just published a study in Nature with Elsa Anagnostou, and we looked at changes in ctDNA for monitoring. And what was interesting was if we just corrected by white cells and leukocytes, that was all we needed to do. So we did tumor-informed versus tumor-uninformed, and as long as we had leukocyte correction, and a lot of these commercial assays do that bioinformatically, we were set and we knew what we were dealing with. So I hope that's a very long answer to, I don't really know, but that's what I think I know.
Thank you.
Thanks for convincing us that liquid is solid in advanced non-small cell lung cancer. And I'm sure with this background, we'll go ahead. What is the role of this liquid biopsy in screening and MRD assessment of solid organ malignancies? For this, we have Dr. Steve Olson, Chief Medical Officer, Guardant Health.
Thank you very much. There we go, my slides. As we just heard, tumors can shed DNA into the bloodstream. But this happens not only in the metastatic setting, but happens throughout the course of cancer progression. And it's possible that we can detect the presence of circulating tumor DNA and use that information to guide therapeutic interventions at various stages of the patient's journey. So we just heard a very elegant presentation about the use of circulating tumor DNA analysis in advanced stage non-small cell lung cancer, and the purpose of looking for ctDNA in that setting is to find actionable alterations that we can treat with targeted therapies. That's the main purpose of why we're doing that. And in this setting, the tumor burden is very large. The amount of tumor DNA being shed into the blood is relatively high, so that we can focus on detecting the genomic alterations, such as mutations, insertions, deletions. We can even find amplification and gene rearrangements by looking at these small fragments of DNA in the blood. And so we just heard about non-small cell lung cancer, so lest you think that this is an assay only for non-small cell lung cancer, my focus throughout my talk is going to be on colorectal cancer, to remind you that there are other tumor types where this can be useful. So in advanced stage colorectal cancer, we did a study in Spain, very similar to the Nile study. About 155 patients were subjected to standard tissue testing and to Guardant 360, a liquid NGS assay. And among those 155 patients, we looked at the common biomarkers recommended by ESMO, and we found that about 60% of patients had an actionable profile. And most of the time, either assay detected that. But you see, and Dr. Lael had pointed this out as well, sometimes tissue finds something that liquid misses, and sometimes liquid finds something that tissue misses. The other finding that we had, very similar to the Nile study, is that tissue testing took about 27 days median turnaround time, whereas the liquid NGS took only 10 days median turnaround time. So it's faster, it's finding alterations at similar rates in the metastatic setting for colorectal cancer. Let's move earlier in the patient's journey, though. What about patients with curable resectable colorectal cancer, okay? They've been treated with the therapy. We feel confident. We've done everything. The surgeon says, I got it all. The oncologist says, I gave you chemotherapy. We got it all. Can we assess whether there is still residual cancer in the body, even after doing everything we know to remove it in patients with earlier stages of disease? Now, some companies are working on a tumor tissue informed approach to detect residual tumor DNA in this setting. And they are looking at tissue. They find specific mutations in tissue and create a bespoke assay that does deep droplet digital PCR testing to improve the sensitivity of the assay, because you need about 100 to 1,000 times greater sensitivity to detect tumor DNA in this setting compared to the advanced stage setting. So how do you improve that? So one approach is this tumor-informed approach, doing droplet digital PCR. The approach that our company has taken is to focus on methylation. So what is methylation in circulating tumor DNA? So methylation in general, especially DNA hypermethylation, is a way that genes are turned off in all cells, okay? You know, the DNA in all of our cells is exactly the same, except for germ cells, right? Otherwise, we have, you know, we have 46 chromosomes in every one of our cells. And why is it that there's a skin cell or a nerve cell? And that is the differential expression of the genes, and this is controlled by methylation. So hypermethylation turns genes off, hypomethylation in the promoter regions turns genes on, and this is what makes different cells different in our bodies. So this is also true for cancer. So certain cancers will hypermethylate promoter regions of some genes, and even hypomethylate certain promoters in other genes. And this happens in many loci. So where we're looking at mutations in a cancer cell, there's only one point mutation. We're looking for EGFR, L858R. In every cancer cell, there's only one molecule of that in every cancer cell. And so we're looking for that one molecule to be shed into the blood, and then we try to detect it, okay? With methylation, there are hundreds of methylation events happening in that cancer cell. So that improves our sensitivity 100-fold over looking at single gene mutations. And so that is the reason that we are exploiting this concept of methylation. There are different ways of assessing methylation in blood. One approach is a bisulfite approach. Its chemical reaction actually destroys a lot of the DNA, and by destroying the DNA actually will decrease the sensitivity of the assay because, as I said, we want to increase the sensitivity, but the chemical reactions involved in this step actually destroys some of the DNA in the process. So you do improve the sensitivity, but possibly not as much as you would want. We take the approach of methylation enrichment. We do a partitioning step, and we aren't destroying the DNA in the process. And so we actually have done studies comparing this approach to the bisulfite approach, and our yield of total DNA is 10 to 15 times higher by using this approach than the bisulfite approach. So this is something that's helping to improve the sensitivity in our assays. This approach has been used and reported just a week ago at the ASCO GI Symposium in the Cosmos CRC01 study. This is a prospective blood collection study in Japan of patients with colorectal cancers that have been resected. We looked at the colon cancer cohort, patients who had R0 resection and had stage 2 to 3 colon cancer, and we looked at blood collected within 28 days of surgical resection, and then we also looked at the blood samples collected just after the completion of adjuvant therapy. So about half of the patients in this cohort received adjuvant therapy. Oh, and by the way, the patients were not aware of these results. This is retrospective, so these results played no role in how the patients were managed. They were managed by standard of care, and then we collected the blood and analyzed it, and we're doing this retrospective analysis. So in this study, if we look at the blood collected within 28 days of surgery, we found that the presence of tumor DNA, by looking at methylation only and without any information about the tumor tissue itself, we found that this is prognostic for recurrence. So the absence of tumor DNA, these patients in the blue curve are living longer with almost 2.5-year follow-up, a little over 2-year follow-up. The median relapse-free survival has not even been met in this cohort of patients. But in those patients in whom we were able to detect tumor DNA after surgery, those patients have a median relapse-free survival of 18 months. So these patients are much more likely to recur. Now, some of these patients on both curves received adjuvant chemotherapy. So what does it look like if we treat patients with adjuvant chemotherapy and then look at the ctDNA analysis? So this is the subgroup of patients who received adjuvant chemo. And again, the patients who did not have circulating tumor DNA detected are having an extremely good prognosis, very good clinical outcomes. But if there is still tumor DNA detected after the completion of adjuvant chemotherapy, these patients are almost all destined to relapse. So it becomes a very useful prognostic tool. Now, moving to even earlier stages of disease, cancer screening. So colon cancer screening usually consists of stool tests. The gold standard in many countries is colonoscopy, but we know that most patients don't want to undergo colonoscopy. Now, patients, these aren't patients, these are healthy individuals undergoing screening to detect cancer early. There's much less tumor DNA being shed in the blood in this scenario. So you need an even more sensitive assay. So our initial approach to this was to take a multi-omics approach. We looked at mutations, we looked at methylation, and we even included fragmentomics, which is looking at an overall global sense of the sizes of the DNA fragments that are in the blood. So it's not looking at any specific mutations, it's just looking at the pattern of the sizes of the DNA fragments, and we know that these differ between patients who have cancer and patients who don't have cancer. So using this multi-omics approach, we ran this study called ECLIPSE. So this is a study of thousands of patients in the United States, aged 45 to 84, at average risk for developing colorectal cancer. And everybody was willing to undergo colonoscopy, and prior to colonoscopy, they also had blood collection to look for the presence of tumor DNA. What we found is that our assay had a sensitivity for detecting cancer of 83%. We found 65 cancer cases out of more than 7,800 volunteers in this study, and a specificity of 90%. We were able to detect very well patients with more advanced stage cancers, and in fact, other liquid biopsies have shown that they're very good at detecting late stage cancers, but more importantly, we were also able to detect early stage cancers. Those are the cancers that are curable. That is the reason that we screen patients. And so this is the first liquid biopsy to show this level of performance in detecting early stage cancers in healthy individuals. Finally, I said that we took this multi-omics approach, but because we have so much experience now, we continue to learn, we continue to improve our assays, we're trying to develop this assay as a methylation-only assay. So we submitted this other version to the FDA, and it's currently under review by the FDA, but we continue to improve performance. We're looking at different tumor types in addition to colorectal cancer screening, and we're looking at methylation only. And we have some preliminary data. These were shown a few years ago at AACR, but we have been able to show that we have fairly reasonable sensitivity and specificity with a methylation-only approach in colorectal cancer. And lest you think we only care about colorectal cancer screening, we have also been looking at this approach in various tumor types, including non-small cell lung cancer. We have an ongoing study for screening lung cancer and other tumor types as well. So, summary. The evolving role of ctDNA for colon cancer. It can be detected at every stage of the patient's journey. Late-stage cancers, it's used to identify patients eligible for targeted therapies. And I've demonstrated, and Dr. Leah has also demonstrated, it is non-inferior to tissue-based testing and has faster turnaround time. We can detect in early stage using methylation approaches. We can do this without prior knowledge of the molecular characteristics of the tumor tissue. So you don't need the tumor tissue to make this assessment with our assay. And the presence of ctDNA after surgery is prognostic for relapse-free survival. We can use this technology for cancer screening as well, and we are able to detect ctDNA in asymptomatic individuals, and we hope that this actually will increase compliance for patients who don't want to handle stool and are reluctant to undergo a colonoscopy, at least initially. Clinical studies are ongoing in all of these areas to look at different tumor types. And this is just the spectrum of the assays that we are developing at Guardant. Thank you very much.
Dr. Olson, that was great. So are you using, for the screening assays, are you using sort of the methylation fingerprinting algorithms that we've heard about with other assays?
Yeah, so
So
the methylome that we've developed, so initially for colon cancer, and we've now ditched this approach, but initially for colon cancer, we did a bottom-up approach. We did a literature search, and we said, oh, where's all the hypermethylation in colon cancer? And then we developed an assay based on that. And then we said, wow, this is very interesting, and we want to be able to look at different cancers. And we realized it would be exhausting to do this for every different tumor type. So what we did was we analyzed the blood of non-cancer patients, smokers without cancer, people with ulcerative colitis but no cancer, people with diabetes but no cancer, just regular people with no cancer. We looked at their blood, and we looked at the methylation patterns of the DNA that we found in the blood of those patients. And we said, that's normal, okay? And then we looked at the blood of various types of cancer patients. And we found, okay, is these areas that are not hypermethylated in normal people, can we see signals there in people known to have cancer? The answer is yes. So we created that kind of this, we call it this blood normal methylome, which is not hypermethylated in healthy individuals. And then we kind of just do the logic where we say, well, if we're seeing hypermethylation in these regions, then that's a cancer signal. And that's the approach that we take. Now, it doesn't mean you can't have just one signal. So, of course, there's always going to be variations, okay? So that's when our bioinformatics comes in, and we use an algorithm to analyze and weigh, okay, what's the probability that these signals are positive, that mean that there's cancer in this person, okay? So that's the approach that we are taking with our methylation assays.
So
sort of say, okay, we think this is very likely of colon origin, or, I'm sort of thinking about like...
Yeah, so we have some preliminary data where we are able to do that. We haven't done that yet. So for the methylation approach in patients where we know that we know what kind of cancer they had, we know what they were resected for, et cetera. That's easy because, you as clinicians give us that information, and, but for early stage cancer, for early detection, yes, we are developing that. And in the future, our goal is to develop a multi-cancer early detection assay. We're not there yet, okay? But that is our goal eventually, and as part of that assay, we must be able to give some information, and we demonstrated that we can, give some information about the site of origin.
So, Dr. Olson, over here on your left.
On my left. And there's
Yes.
a big light,
Okay.
and I'm very sensitive to bright light,
Right.
so I can't see you.
So perhaps I'm the only baldy over here, so perhaps now that makes it easier for you.
I see your name badge. But
Perfect.
yes.
Perfect. So that was a great talk. This was a bit intriguing as well. You are primarily looking at the CFDNA, and essentially which would be constituting about 98 or 97% of all the free DNA out over there as opposed to the ctDNA. Despite that high CFDNA, it's very intriguing that why would the methylation pattern of a somatic disease of a specific tumor type would be different, and that would carry some signature. Possibly you are alluding to the proportion that is being affected by the ctDNA. So is there a qualifying another that there should be X% of ctDNA to qualify for these methylation pattern to be significant, that would be distinct, or that would allow you to discern between a cancer patient and a normal?
Yeah,
healthy?
sure. All of these assays are dependent on the amount of tumor DNA being shed, because there is a level of detection that we have with our assay. And so we don't call, so there needs to be enough for our assay to pick it up. Absolutely. And so that's the reason, none of these liquid biopsies and even no screening assays, for example, are 100% perfect. So there are times when there's just not enough tumor material in the blood for us to detect. That does happen.
Or are you alluding that it is the CFD, it is the non-ctDNA aspect, which is also different in these patients?
No. Well, actually, let me take that back. Theoretically, and we are looking at this from a scientific perspective, that what you're saying is it's possible. Let me go back, though. The purpose of the assays right now is just to detect the presence of cancer, so we are looking specifically for cancer-derived signals. But it's possible. What if the stroma around the cancer, what if the cells in the stroma have deactivated certain genes, and they are shedding DNA into the blood? What if that is happening? We know it does, actually. That is being shed into the blood. Are we picking up those signals as well? And that is possible. And it's something that we're looking into because we think that that is also going to help us further characterize the tissue of origin. But we're not there yet.
Thank you.
All right, thank you, Dr. Olson. So keeping in the flavor of liquid biopsies, after two fantastic talks by Dr. Leal and Dr. Olson, I'd like to invite Dr. Nitesh Rotigi, who's our moderator, for a panel discussion on emerging role of blood-based tests across the cancer care continuum. Would you like me to introduce?
Thank you. No, I have four panelists. I'm really honored, actually, to be inviting this panel, but I'm really going to give you a role each. So I'll start with Steve. Steve, can you please come as a panelist? And Steve's role is to be utopian or futuristic, whichever way he decides to be. But clearly, from what we just heard, I think it's fascinating where this whole field is going. And Steve, thank you for that lecture. Natasha, please. It's been great hearing that lecture. And Natasha's role is to be where she is in the West and see how this works in the Western practice. Dr. T. Raja, we all know him. He's the guru of precision medicine in India. I think we've learned more from him than we have learned from any of the books. And so your role is to put that practice in the East.
Somebody who doesn't know anything, so randomized.
And Bhavna Suri, a very close friend, phenomenal. And her role is what she does best, which is choosing wisely. So I think we'll have some interesting discussion. The idea here, okay, this is not mine. I think yeah, okay. I have a different set of slides here. I think somebody needs to change those slides, please. also, sorry, can I invite Vikas Talreja? Vikas, I'm so sorry, I forgot. I got so excited by the star-studded. And Vikas is one of the brightest, youngest stars in medical oncology in India, working from, Vikas, you're in Kanpur now, right? Okay, Vikas from Kanpur. And so the question is the emerging role of blood-based tests across cancer continuum. And we just saw Steve's slide. It's going from early detection, or rather, actually, let me turn it around. It's going from advanced disease to early detection. And Steve, I'll pass the mic back to you. Do you think, because this whole question of early detection means we're going to apply it to the whole population. How futuristic is this, where we will be actually checking the whole population for looking for cancer?
Yeah, the answer is yes. I think the future is this is what's going to happen. Now,
how? When?
Yeah. Will it be in our lifetime? Maybe not in my lifetime.
Oh.
But I think that assays will be available. The challenge is that the idea exists. The technology has not yet caught up to the concept. The technology will catch up to the concept. And maybe it could be within my lifetime that it does. You know, my company is working on it. Other companies are working on this as well. So I think that's the future, like a multi-cancer early detection. People go in to get their cholesterol checked, and then they also get screened for cancer in the same blood draw.
Bhavna, choosing wisely question here. We know that India has a somewhat defragmented control on these things. And once the test's available, people are going to do it, even if it's not validated, even if it's not recommended. How do you control that? Because it's real for us.
So, and it's already happening.
It is happening. That's exactly what I'm saying. It is happening. We are trying to detect cancer not by 99 anymore, but by ctDNA.
Yeah, and I just had a patient with the report. I tweeted about it. He's had a PET scan as well, but not had a stool fecal occult blood test, you know, which is so simple to do. So I think we just have to educate, and train people, because that's the only answer. There's no other way to get around it, because I think it's patient-driven as well, because patients come to you and demand the test. They demand a PET scan because they've heard it that, you know, they should have it. So it takes longer to explain to them that why they should not have it.
And that's been the lacuna as well. I think we are at fault. We've been talking a lot amongst ourselves, but we really not gone out there and challenged the dogma from patients' perspective. We haven't gone out on the media and saying what the hell is happening and stuff like that. Natasha, MRD, that was, I mean, that's what Steve showed there was nothing short of a science fiction movie where, you know, you're using some basic methylation, hyper and hypermethylation. And I know you do a lot of early lung cancer, and I know a lot of work, including the latest atezolizumab trial, is going to be on MRD. Are we seeing signals there where MRD will take center stage for early lung cancer?
Thanks. I agree. I think we're definitely going to get there. We need to improve the technology. So, you know, that prognostic signal is clearly there. The literature, though, is very variable, you know, because ctDNA is so closely associated with metastatic potential. In early stage disease, risk, you know, is not always, you know, things haven't always metastasized yet. So if you don't have nodal involvement, the chance of finding MRD is much less. And so, you know, particularly with adenocarcinoma, which is so important, you know, I think we need to improve the technology, we need to improve the machine learning so that we can make the calls in those smaller tumors.
How far do you think that is?
I mean, I would say less than 5 years.
Okay.
Steve and his team are working on, you know, tumor agnostic assays. The machine learning's already happening.
Yeah.
You know, teams like Max Dean
I
are
think
working.
it is at a doorstep. I would be least surprised if it's less than 5.
What is the Eastern answer? I'm going to say 5 years in the West. What do you think in the East for MRD?
Dr. Raja is saying I'm already using it.
There are clinical situations. So I don't want to be sounding like an expert what they are, but I can talk like a clinician. So have I done this today in these settings? The answer is yes. I have patients in whom where I see, I'll give you a couple of examples. I have patients who are colon cancers, familial syndromes and all. So I have used ctDNA to monitor after resection and early stage colon cancers, ctDNA follow-up, and then advanced stage, a couple of malignancies where I have definitely comfortably used ctDNAs and CTCs to monitor. And I have patients in whom there are, a patient with a liver tumor, wherein it was there for quite a few years. There was a dilemma whether it was a vascular tumor or a malignant tumor. Resection was the best answer, but the resection, he had a renal dysfunction. The resection would invariably land him into a dialysis dependent situation. So I have to take a call whether this is malignancy or not.
Tough.
It was very important for the patient, very well profiled, very affording. So we did a ctDNA and a CTC, and if it turns out to be positive, so would you tell them? He says that if I go for surgery, I will end up dialysis dependent, but if it comes back as pathology non-malignant, I'll be very upset, doctor. So how do you take the call? So are you going to run away from that question? So there are situations in which we do use, I think we are there already.
Yeah, and I think the change I see is that now at least the technology is there for it to be individualized at times, but I agree to what everybody else said.
The other quick example is HRR testing.
Yeah.
10 years ago, ethical questions about HRR testing. Today, the families come and ask you, can we do in a directed family history patient?
Yeah.
So things, India catches up faster.
Very
That's the
fast.
answer.
I think the clinical utility, I agree the prognostic value is tremendous. We're already there.
Yeah.
But the clinical utility of treating something, we have an early stage study where we're following ctDNA. Sometimes it disappears, sometimes it appears. All these things about kinetics we don't understand. We have one patient, she's done very well. She's always been ctDNA positive. She's in remission, she's EGFR positive, she's on a TKI. We've never cleared her ctDNA, but she's lived longer in remission than anybody else. So still a lot.
Vikas, and I will ask you one more question because I know you're a very keen clinician. Natasha's talk on concordance was quite interesting, and we will come to that at length. But are you using liquid biopsy in your setup?
So I have been using a lot of liquid biopsies, and the question of whether using it or not, I believe in screening, recurrence, and therapy selection, there is a lot of information that is coming from these liquid biopsies, and I believe the next question that we are going to ask 1 year from now is, can I get a cancer?
Yeah.
So with that information, the radiology imaging, the mammographies, the x-rays, they are putting up artificial intelligence
And
algorithms,
hopefully.
and that's where you're getting a prediction of getting a cancer.
Yes.
Now with that liquid biopsy in place, with an early detection, now you don't have a cancer, but with that profile, can you get a cancer? That's something which is promising in future.
I am short of time. I will run forward. What he's saying is absolutely right. I'll be adding more to this in 2025. But the world has changed in the last 10 years. The cancer was clonal, now it's polyclonal, primary cancer-specific therapy, now it's molecular targeted. Immune therapies were never worked. There was a Times article on how this may be a scam. It was not 10 years, maybe it was 15, 16 years ago, but how it could be a scam, and now we know what it does. Molecular testing is some broad spectrum. The first molecular test I sent when I was in UK was 2005. It took 2 months from Germany. Now 7 days is what Natasha just showed us in her trial. Randomized phase 3 single-arm studies are being used, rightfully so or not, we don't know. Microbiome was smelly and disgusting. Wow, I mean, we are only talking about microbiome now to make immunotherapy work. Cost of treatment was high, cost is now quality-based, and testing is less than half a dozen research centers. Now I think it's going to open in shopping malls very soon. TAT was 2 months, and now TAT is 7 days. So that, and I think, Steve, you hit the nail on the head. Multiomics, the methylation, the AI, everything is changing. So with that came in the question of liquid biopsy, right? Let me go backwards here. Vikas, when in clinical practice, would you use liquid biopsy over and above a tissue biopsy? Generally, yeah.
So we have radiographic response, we have clinical response. Now we have this molecular response. I believe it should be done at every step.
Including a diagnosis?
Including the diagnosis,
Okay.
because at the end of the day, you want all your areas to be covered. You don't want 2 years giving an EGFR positive patient a chemotherapy at the end of the day. So I would say that do it for
Dr. Raja, in which situation would you prefer it to a tissue biopsy? At diagnosis, patient has had, let's say, a pancreatic tumor diagnosis already made. Would you do a liquid biopsy at diagnosis over a tissue biopsy?
Practical answer is whenever a tissue biopsy is possible, we do a tissue biopsy. Whenever it is not possible, we do it. That's an easy answer.
Okay.
But longitudinal monitoring,
Yeah.
I mean, has already come into play. And I have been using longitudinal monitoring for the past 3-4 years.
Especially lung cancer.
Yeah, definitely. I have already been using longitudinal monitoring, and so serial liquid biopsies, in fact, you are one of the pioneers, and I have seen your patients having, 3 monthly, so all that. So we are all using longitudinal monitoring liquid biopsies. The interesting question is after Madam Natali's and Professor Olsen's presentation is that the complementary detection, the detection rate improves, and we all know about the heterogeneity issue. So liquid biopsy adds to the value of knowing more about the tumor heterogeneity. So therefore, the scientific or clinical answer is that, if possible, should be done together upfront at diagnosis. Helps you in many ways to know more, to know about the heterogeneity, to follow up, and also response assessment. We are in the cusp of de-escalation, escalation, all that.
So let's address that. So my next, I'm coming to you in a second. My next section was complementary. I'm going to club both of them. And I'm not the pioneer, actually. Natasha was the pioneer of liquid biopsy in lung cancer, where at ASCO she showed the most beautiful colored graphs in ALK positive patient, and we were like, oh gosh, I mean, we can really use this technology. So I think the two questions Dr. Raja is asking is complementary. Is it really beneficial? And I think from what I'm understanding is really from the point of view of monitoring as well. So you do complementary, and then can you monitor that? In contradiction to what you said, some patients may not clear, but maybe it's not escalating. How do you solve that whole puzzle?
Thanks. So I'm probably not going to answer your question, but I can tell you where we use it or where we think the data are great. So obviously, if tissue NGS fails, you have to do it.
Yeah.
Resistance, we think it's preferred as a first step. Complementary, at the beginning, we truly believe that it gets more people to the right answer and it saves money downstream. So we're hoping to hear about funding soon. We've even taken it a step further. We have a project called Accelerate that we've published on a few times in the last few years, where when the patient comes and they have suspected advanced lung cancer, we do the liquid biopsy, then we get the biopsy, but by the time we get the biopsy, we have the molecular, so we can start the next day. And that cuts our treatment time in half, or time to treatment in half, and so that's actually what we're doing at our hospital now. MRD, monitoring, fascinating, but how much is enough? Is it really worth it for patients? Do you change quality of life?
Yeah.
Is it just lead time bias, right? So I love it. It's coming.
Yeah.
It's here in the East. In the West, we need clinical utility.
Bhavna, I do need to ask you this question, because I think what Natasha just touched upon is choosing widely question, right? Sorry, Dr. Raja.
One thing is already clear, Nitesh, that early detection by both ctDNA and CTC clearly have a different prognosis. and the survivals are all already demonstrated.
Yeah.
But whether acting on it has changed the outcome or not is the only question we are.
Yeah. And
that's where we
I
are.
think that's what Natasha was trying to say,
That's
that
the
we have to
trouble
prove each
still,
step.
whether we are right to act on it or not is the trouble.
We have to prove each step. Bhavna, choosing wisely question, right? Now there's a big difference here, because we do get the tissue or liquid complementary. So our cost in India doesn't go up when we do complementary. And to the Vikas's point, it will help in monitoring. So do you think it's therefore wise?
So ideally, I would do both, because we've all discussed in our tumor boards as well. In GI cancers, which I do mainly GI and breast, beyond second line, we are really stuck. And we've had stomach cancer patients where HER2 negative on biopsy, but they are positive on ctDNA. On colon cancer, we can re-challenge with cetuximab with the EGFR story. So I think ideally, if cost was not an issue, I would do both. And I'm most excited about in liquid biopsy for cervix, breast, and head and neck in India. I think we are fine with clinical. But for colon cancer, there is a kind of an epidemic. It's rising so much in younger people.
Rectal cancer.
And we have an inherent cultural issue with sending a stool sample for fecal occult blood. But doing a blood test, so that is one space which I'm really excited about.
Yeah, you just completely messed up my flow, because that was in the end. But Steve, this is very relevant what Bhavna is saying. We are observing that colon cancer is the fastest rising cancer in India. This is observation. We don't have data. I have asked this question to at least 25, 30 of my colleagues. Colon cancer numbers, in each of us who've been practicing for 10 years or more, we've seen a rise. How practical do you think this technology is at a mass level, at a state level? We have a very state, we have a lady called Ms. Kausa there who works across the spectrum at state level, at advocacy level. So how practical is this to send in the post and have a blood test collected and sent back?
Yeah, so I think it all comes down to, cost effectiveness.
But that's a scalable question. With scale, cost goes down.
Yeah, if you do enough of it, yes, the cost will go down. So if the volume is high, the cost will come down, right? And so, but I just think it's, the thing is, and we've been saying this in the United States, because there's lots of different, so in the US, there are lots of different colon cancer screening approaches that are available, and there are various companies, making money off of their various approaches, right? And I work for one of those. But in the end, screening is better than no screening, okay? Colonoscopy, we consider to be the gold standard. Not everybody's going to go for colonoscopy. People don't want it, okay? It's time-consuming, it's exhausting. And the screening test that gets done is better than not screening at all.
That's the bottom line.
Yeah.
Because no matter how hard we try, fit just doesn't happen. People don't do stool for occult blood. And that's a reality in every country in the world. And the big problem I see facing, from Bhavna's point, is that most of the studies, including yours, was done actually predominantly in the elderly age group, while we are seeing young colon cancers in India. So maybe we do need to do our own study. We do need to do our 18+ study on the same screening platform and see what happens.
Yeah. And the other thing about this, the test that gets done, we have some preliminary data suggesting compliance. And when people say, oh, please get a blood test for colon cancer screening, or please get some stool-based test, clearly the compliance for just getting a blood test is very high. It's about 90%. The people will have it done because it's so easy.
Not only that, I think it's something about human psychology. We like doing blood tests. We think it is very useful. We are going to get something out of it, And I have seen patients being disappointed that my blood test was entirely normal. What's wrong with your testing? So we do like doing blood tests. But now I'll start with you again, because you were showing this methylation and based on your very new and interesting Infinity platform, which is multi-omics platform. How mature do you think it is? And I think that's raising Amit's point. Do you think that this is the first step of a very complex matrix, or do you think you've already cracked it and therefore this is going to be the technology as it stands and we're just going to see better usage of it? More usage versus improving technology.
Yeah, so I think, well, we still have to improve I still think we have to improve the technology, but we also have to better understand how we analyze the data. So we get a lot of signal coming in whenever we do one of these assays, terabytes of information. And how do we analyze that? And do I think that methylation is the only way forward? I think no, but I think it's a very important part.
One step.
Because the potential of methylation is it can tell you so many more things, not just the presence of tumor, but it can tell you,
It's a big change.
Where is the metastatic site? You could say, okay, I did surgery for colon cancer, and now I have this signal. Well, maybe we can also derive from that signal that, this is probably metastasis in the liver. So why don't you image the liver very closely?
This was most fascinating. Hypothesis generating, but most fascinating that post-surgery, not only do you know it's going to come back, but you know it's going to come back in the liver versus lung. Yeah. Because the methylation of liver and lung is likely to be different because they interact differently. Yeah. Very fascinating. We have very little time. Bhavna, you do a lot of colorectal cancer. This is a very interesting schema of Lunar 1 where basically they say, is ctDNA negative? These patients do so well, that's fine. If it's positive, let's give chemotherapy. But interesting, look at the second step. If it is still positive, they're changing chemotherapy. Do you feel that there is enough confidence and is this the kind of approach which is likely to do well? Dr. Raja, your opinion on it after Bhavna's.
So I feel, we spent years doing trials with irinotecan, cetuximab, bevacizumab in adjuvant setting, and they were all negative.
Yeah.
So I feel that, then now to bring it on after oxaliplatin to give FOLFIRI, I just don't buy it. And because, you know that it hasn't worked, so why do you want to do it now?
So the theory is, and the argument there is that if a patient is still ctDNA positive, the group believes they are certainly going to be metastatic, and if your metastatic treatment is FOLFIRI.
We don't know the clinical utility of it. And it has to be shown in a randomized fashion that yes, it makes a difference.
Which is this study which will come
which
out.
Hopefully it will tell us.
Dr. Raja, your view on this as well? This is basically being very dynamic with ctDNA and.
So in the early stages, very difficult until we see. But if you want to draw some analogy from a metastatic setting, we just last year had the publication in ASCO in breast cancer, endocrine sensitive disease, just presence of ESR1 in ctDNA detection, and you change the therapy and you've already shown the outcome difference. So it's already, the concept is proven in that setting. The only question is some sort of proof needs to emerge that an early intervention, lead time bias and all those, finally.
Will have to
so
be
if there is some hint that early intervention, particularly in early stage, still it's a holy grail area, will make a difference, and I think everybody will jump into it.
Excellent. Last question, first to Natasha, then to Vikas. And please, you'll have to forgive me for going left and right, but you all mucked up my slides. I didn't. I had them well organized, but the discussion went round and round. This was very relevant to me. We have a huge lung cancer population, Asian non-smokers, huge population, growing in fact. And we do end up getting biopsies read on RT-PCRs and some hotspot NGS. And to be fair, we do miss, but by the time we missed it, the patients actually start losing somewhat faith and they don't want second treatments and second biopsies. In how many of these patients that you're showing, close to 15-20%, was a different method equally valid, or this was the only method? What I'm trying to say, that is doing complementary testing by far improving just picking up more information, or it actually increased the total cohorts survival, for example?
Thanks. It's a great question, and I think all of our studies need longer follow-up.
Yeah.
But I think there are a couple of things that are good predictors, right? So we found more actionable targets. We got more people on targeted therapy. People with targeted therapy had better quality of life, better progression-free survival. We're going to look at the overall survival.
Yeah.
Sanjay's going to look at that. We're all going to look at that. So I think it all tracks, and I think that we will see that this directed treatment versus undirected is superior.
Okay.
Plus all the toxicity of immunotherapy that doesn't work. And then I think, the next step is these very fancy AI, not just one gene, but, the 12 alterations, and how do we target
Okay, my
those?
time is up. Vikas, I'll start with you, then we'll go that word for the last words. Last word starting only with one comment. You've had a patient who was caught with a targetable mutation on liquid biopsy and you had already started immunotherapy by then. Has that happened? It has happened with me.
Sorry?
I started with immunotherapy, chemotherapy, and the patient had the EGFR deletion 19, which was missed on the tissue. And so, I was gutted. It didn't do any harm, but I was gutted. Has it happened to you? And your last words on the whole topic.
So it does happens that you start, so what I usually do is I start with first chemo and then add immuno if the molecular is negative. But it, as I said, that cover all the grounds, liquid and solid, it is necessary at the end of the day. And also important is 30% of our patients don't go up to the subsequent lines. And that's where
Early treatment is very
and
critical.
we regret at the end of the day we would have done earlier.
Dr. Raja, your last comments on the whole topic. The whole topic of liquid biopsies and complementary testing and MRD screening, everything. Your
I'm
last.
trying to use it more. I would recommend everybody to use it more, no question. I will also request and recommend that the cost should come down from the stakeholders. I think it is definitely going to be useful. And to your worry, FLARA2 data is already there. So even if you have started chemo, doesn't matter if you have an exon 19, you can add the osimertinib. So, so these are all not the issues. But this is an inevitable technology cost constraint.
Excellent. Natasha, last words?
Thanks. So I think we need to keep pushing all the areas where we know it works already, getting the right people to not the right people, but all of our patients, the right treatment earlier. But I also think we need to push the boundaries. You could have a blood test that says whether or not your cancer's back. You don't need to do the CT scan. You don't need to do the scanxiety. So I think we need to start pushing all of the ways that we could use this and move even beyond genotyping, treatment selection.
And the long-term follow-up. I think that was a very relevant point you made. The long-term follow-up will tell us more. Bhavna, last words?
So I think we just need to make sure that there's clinical utility before we order the test.
Yeah, very good point. Yeah, we should define that actually. Steve, last words? You were the utopian man, remember that.
As a medical oncologist who works for a company, I encourage everyone, when you have the opportunity to participate in clinical research, please do it.
Excellent.
Because we need the data to justify the decisions that we're making in clinical.
Very valid point. Excellent. Sorry, Dr. Raja, please.
One question. I just wanted to ask both the experts how far they have gone in RNA sequencing in the liquid. Because, will that be reality soon? RNA sequencing is happening. Do you do a complete whole exome sequencing in the liquid?
Yeah, so RNA sequencing in liquid is tricky because RNA is not particularly stable in blood, and there are some ways of stabilizing for it, but it is a bit challenging. But people are looking into that approach. That's all I can say about that.
There are a number of platforms that are emerging with RNA. And I was actually just reviewing a very interesting paper looking at RNA of supernatant from biopsies and how you're able to just get it off there and it's more stable. So I think you'll see more RNA.
Thank you very much. I will have to stop there. And again, it was an honor to have the most elaborate and who's who of the world of NGS here. Okay, Kosa has a question, but I'm running short of time. So if you don't mind, can you speak to them later after? Thank you. All right, bye.
All right, Thank you, Dr. Nitesh and panelists. Let's take a slight shift and actually go through what we were discussing earlier about how do we read an NGS report. So we've got Dr. Amit Verma, So we've got Dr. Amit Verma. He's the founder and director of Dr. A.V. Cancer Institute of Personalized Cancer Therapy, who's going to walk us and shed light on the nuances of step-by-step on how to read the report of NGS.
So thank you, Aparna. May I call my panelists, the esteemed panelists, Dr. Aparna Dhar, Dr. Vikas Talreja, Dr. Anuradha, Dr. Om Shri Shetty, Dr. Manmeet, Dr. Gohar Shafi. And can I have my slides, please? These are not my slides. So, we'll talk about step by step how to read the NGS report, but before that, the simple basic question comes to in my mind is what are the real expectations when we order an NGS test? So you have to set your expectations right before you really start interpreting the report. So I would like to ask my esteemed panelists, you can just give what are the expectations in the real world whenever somebody orders an NGS test? Dr. Gohar, just tell me what are your practical feedbacks on this?
Yeah, I think it's very important, when we get a test, first we should get some kind of information what a clinician is looking for. I have seen, when we send a report out and then they were asking, we were expecting EGFR or ALK positive. It has been also seen in other labs where they have tried to look for those mutations and they have not found it. But what I expect from the lab side, it's very important we have a complete history of the patient. It becomes very important when we get, because the interpretation is very critical if I don't have a complete information for that test.
Okay. Because as a clinician, when you order a test, what are your expectations?
So I would categorize those expectations in subcategories. There are physician expectations.
So, everybody has their own expectations actually, the same test.
Then there are patient expectations. Okay. Then there are molecular oncologists who are reporting that report expectations.
Okay,
then there are cost expectations. Then there are company expectations as which company to put on to it. So expectations can be as many as it. So, as a physician, when I send a report, I see how approachable the scientist who the reporting is, how much the cost effective the test is, what is the panel of the test they are covering, and the turnaround time. So that's
yeah. As from the clinician's point of view, I think the clinicians look to which lab are we sending, whether that's a CAP or NABL accredited, because there are no guidelines as such and NABL. Then second thing, what are we ordering? Whether are we looking for driver actionable mutations? Are we looking for prognostic and predictive markers in that? And what are the fusions, and is it a RNA-based or DNA-based? And depending upon the disease, what are we ordering for?
Perfect. Dr. Aparna.
So yeah, just to further elaborate on what Dr. Anuradha said, and what part in the patient's journey are you actually incorporating NGS? Is it upfront? Is it second line, third line? That actually helps us evaluate and understand what sort of an NGS test we're looking for, which in turn allows us to look at the technical aspects of a test and decide, should I go for CGP, 12 gene, etc.
Yeah, exactly. To add on to everyone who has said, whether it is a hotspot panel or it is like a complete exon spanning panel, it's a clinical exome, CGP, targeted panel, and how much of tumor tissue is actually there. So these are the additional things. Yeah.
So what we heard from different perspectives, the same test, the expectation is too much. And can we really say that really we failed the test or passed the test because expectation can be different and you cannot really fulfill all the expectations? So this is something very, very important, how to interpret a test. Somebody is happy with the prognostic value itself. Somebody is looking only for predictive markers. Somebody is looking for the residual disease, the MRD. So even the negative test is important for them. So many people have a different way to see the same thing. So anyway, the clinical utility of the NGS, as already enumerated by the experts here. Also, we are also looking for the clinical trial enrollment criteria, actually. Whenever we are looking, especially in these scenarios, we are looking if we are able to find a unique biomarker which may be very helpful for the patient. That's an additional expectation. So ideal NGS panel can be discussed, and we have the things which are approved as per the guidelines. These are the genes which should be included in the panel as per the guidelines. But the question goes to the experts here, that what do you recommend? Do you recommend a disease-specific panel, or do you recommend a universal panel which is universal, actually? So then the expectation will also vary. So comes, Gover, your lab offers a universal panel for all cancers, or you have cancer-specific panels to offer to the clinician?
We have, both comprehensive panel as well as, targeted panel. But, like going to the question, if we have a patient who's already advanced, whom, like non-small cell lung cancer, who might have been already EGFR positive, has shown resistance. And I strongly feel that situations, comprehensive profiling is important, because it can explain us the resistance mechanism as well as, some other targeted options for that patient.
Okay, so let me give you a scenario, Dr. Talreja. We have a sarcoma patients. Does any of these tests is going to help you?
So I totally agree that we should be starting with a directed panel rather than the universal panel. But at the same point of time, three things that I put into mind before ordering the panel is how symptomatic the patient is. So because if I order a universal panel and that patient is not going to see 4 weeks or 3 weeks time for my treatment decisions, I believe that's something which is very important. Very important second point is how actionable and how the report that's going to come out, how much affordable options are there. And the third, I believe, is how I'm going to interpret that report that's coming out of it. So as you said, sarcoma, all of these are going to be a useless investigations for it. But at the same point of time, if we are on the third line, fourth line of sarcoma, exhausted of standard line of options, we are in a dark zone, that's somewhere we're going to be a shining ray of hope.
So again, the interpretation is context dependent, and the panel recommendation is also the context dependent. And a simple enumeration of these factors I have just put, just to save some time, I'm just going to the slides. But practically, there are plenty of variables to consider whenever we recommend a NGS panel. If somebody is happy enough to make his life easier, the CGP is a simplistic approach. No things asked, and you can get it. And then you learn over the years how to use it for all your cancers. That's another approach. But somebody who is limited with the economics or the turnaround time, the limitations, a smaller panel can easily give the answers. But other factors which sometimes play a role, specifically the secondary mutations, the microenvironment, you cannot get those answers by smaller panels. Somebody who wants to have a holistic view of the disease or the prediction or the duration of response is something which we don't talk about that much. Early failure is a big challenge which we never talk about. So all these things can be really talked about by a comprehensive panel, and especially whenever the scenarios with family histories, germline can also be easily taken care if a panel is exhaustive. So we talked about the specific and the universal panel. Okay, so let us go to how to interpret the NGS report. That is the key discussion for today. So we have this report, which is not that clear, but a solid tumor biopsy and a liquid tumor biopsy. But whenever we see a report, the first thing what comes to your mind is what? Aparna, it goes to you.
So A couple of things. The clarity in which it's reported, right? So step one, I want to know the tumor fraction, if it's a liquid biopsy, the tumor fraction rate. That kind of helps me assess and understand how confident I am with the results of a liquid biopsy. Similarly, in tissue, I want to know the site of biopsy, I want to know the tumor content, the specimen site, the tissue that has been tested. That has to be very categorically, very clearly written. Then it comes to what is the indication I'm testing for. So ideally, this is what I'd start looking for. And based on that, very, very clearly, the mutations that have been reported, with their FDA approved or something that's approved in a different indication. So that should be very clearly written with the VAF, and maybe treatment recommendations are not, but at least the pathways that which these mutations belong to. So on a periphery search, when I just look at it, it just helps me assess a report a little bit easier. Variants of uncertain significance should be very, very clearly mentioned as VUS. A lot of times they're not, and they get misread. So I think up front, this is what I'd look for in a good somatic NGS report.
Okay, so I want to add a point before I go to Dr. Om. The biopsy timing and the analysis timing is very, very important. So whenever we see a report, we have to see liquid biopsy is definitely a dynamic test. It is the recent most test for sure. But for the tissue analysis, whenever we say, we have to pay emphasis on the biopsy specimen, the number of lines treated, and then when the test was carried out, because interpretation may change altogether. Anyway, so Dr. Om, regarding the ideal NGS panel, whenever we see a report, what are the factors we normally see that this is ideally reported? So it is done in a perfect way. I've just omitted few points for your reference. If you can comment on these things, are they enough, or do you want to omit few of them? They are not necessary, or you want to add few of them actually?
So yes, rightly mentioned the patient information, the demographic details, and what is the disease, the patient age, and when the sample was taken in the lab and the requisition date, I mean the test request was raised. Then again, the histopathology details, the tumor content, whether it was adequate for molecular testing. Then of course it will be there, whether it's an accredited laboratory. And the test details, like what kind of a test was being performed, what platform was used, what panel was used, and what bioinformatic pipeline was used in that. And the mutation annotations, whether it is as per the standard recommended format, whether it is there, the nomenclature is uniform, whether it is HGVS, whether the genes are coded properly. And if you're mentioning the certain alterations, then the tier-based classification using ACMG guidelines or AMP guidelines. And then whether, then in detail you will mention about, what are those alterations, what is the variant allelic frequencies, then the cutoffs which the laboratory has set up, whether what more than that would be considered as actionable, and also what are the databases which have been used for annotations, like the mostly ones, so that the clinician can have the confidence on that data which has been reported, and also the limitations of the assay and what could be the challenges and what else can be done with this. Then in detail you would go on explaining that specific alteration with specific pathways.
So truthfully, it is an encyclopedia actually. So it is too tough for any single person to really interpret the report in such a detail in a span of 5 minutes of interaction of clinical interpretation of the report per se.
Yeah, I agree totally with Omshri. This is regarding the tissue specific, right? But nowadays, since liquid biopsy is frequently been done, I think we need to mention what is the ctDNA yield, because a lot of the genomic DNA contamination happens, and we don't come to know whether is a true ctDNA.
So more new
NGS
technologies,
panel or
more
not.
new things to be added to the report, and the report is going to be 50, 60 pages in the next few years, I can say. Go ahead.
I think, I would like to add one point. You mentioned about the tissue, how old tissue is. In India, what we have seen mostly, sometimes tissue is 2 to 3 years old. And we know the cancer is evolving, and we may not get the current picture. Second thing is, since we are talking about now liquid biopsy, and the transportation of the sample from hospital to the lab, as we know, the temperature in India is not as room temperature as it is in the Western countries, and we have to pay the attention to that also, because that plays an important role when sample is getting transported. It's not ambient temperature, and then you will have a lot of noise there. Therefore, you may miss a relevant signal there.
But I think strect tubes do cover. I think you should not accept the samples if you receive beyond 24 hours or so, or 48 hours, whatever the strect tube mentioned. Otherwise, with the strect tube, it's fine.
Yeah,
so
we have seen the
pre-analytical
difference.
quality is
Temperature, we have
equally
done that.
important. The pre-analytical quality is equally important as not only the analytics part of it, and that has to be also taken into account when we interpret the report, whether it is true negative, true positive, false negative, false positive. Even the sensitivity of the test will go down if the things are already long enough in terms of transportation. So points is very well taken. So many variables while we interpret the report, we should not only look for the genetic alteration and we should bank upon it. There are other things to taken into account before we really make the judgment. That is a take home by the discussion. So in interest of time, we'll switch to the gears so that we can make best use of the time. Already talked about the tire system by Dr. Anuradha, and this is the things we have to make sure that what exactly you are dealing with. So genomic signatures is something which comes along with the genomic report actually. So genomic signatures, the relevant which we all are familiar with, but there are new research-based tools are also coming into picture. I have enumerated few of them, and DNA methylation, we have just heard the relevance in the screening part of it. But eventually you may see that these genomic signatures will also come into your diagnostic tool very soon, and then the interpretation will also go different. So what we are interpreting now may be different, maybe in next 2 years, the same report. That is my personal view on it. But just a simple take home, if somebody reports high HRD in a prostate cancer versus pancreatic cancer versus colon cancer, does it make a difference in terms of treatment? I understand the guidelines are not there, but when I recently came across a case, a pancreatic cancer, not a pancreatic cancer, it was a bladder cancer with HRD score of 36. I was tempted to use the PARP inhibitor, but what is the take home or a message to the audience here? How comfortable we are reporting, one, what are the limitations of these genomic signatures in a disease-specific manner, and how strong data we have in terms of applying that into the clinical practice, actually. Dr. Talreja.
So I would say that whenever we order such expensive tests, it should not be the liability of only the clinicians. It's also the team effort that should be put into putting us safely from the medico-legal point of view, put that report, every report into a molecular tumor board so that everybody shares their opinion, have implications, because whatever our limited experience has been, there is someone with more experience and some differential angle to it. What it adds to the score is what you're interpreting as clinical utility might not be just a noise that is coming out. What depth at level which it is coming might not be clinically usable. I find a PIK3CA and I say that yes, it's mutation, but what level of depth it is coming, what variant it is coming, whether it is specific for that disease, and whether it is agnostic or not, it's going to be put into that molecular tumor board. That's the carry home message.
So what I can hear from the expert, that the interpretation is not straightforward. It has to be a consensus developed among a small group, what we call as molecular tumor board. It can be accessible through physical or virtual approach, or a phone call away to a doctor or friend, what you did in this case. So this is something which we have to do. Interpretation is not straightforward. So we'll see if we can come up with some new cases, actually. So the slides are not functioning that well. Anyway, so this is a metastatic CA lung, and we have the genomic finding of exon 20 insertion. So we all are familiar with exon 20 insertion, so that is not the question. The question here is, we have a PD-L1 of more than 50 and EGFR amplification. The question goes to the expert here. What are the implications of other alterations, what we are seeing, the MTAP, the CDKN2A, the PD-L1, EGFR amplification besides the EGFR exon 20? So Dr. Om, starting from you.
So EGFR exon 20 insertion, alteration along with amplification, so definitely this patient can be considered for EGFR directed therapy. But bad news over here is that there is MTAP loss and CDKN2A loss is also there, along with TP53, which would indicate that the disease progression is really, poor prognosis, because this could be a prognostic indicator. There could be an alternate mechanism for resistance.
So the question goes to you again, that you are saying that EGFR 20 insertion treatment, amivantamab, can be offered to the patient, but what are the implications of EGFR amplification on exon 20 insertion? So now you have two targets. So will it be really helpful?
The information I think real first to go for is for EGFR exon 20 insertion rather than the amplification, because you do have directed therapy for that.
Okay, so you want to add, Aparna?
I agree with her.
Okay. So I think we don't have the right answer. Do we really need to escalate the amivantamab dose up or down based on the amplification? We don't know. Though it is a very toxic drug already, but we don't know, the expectations should be set right. That is the interpretation what I'm talking about. It has not to be a single interest or gene of interest is seen in the report, and I'm very happy and it's a gaga about it that I have done the things. So regarding the MTAP loss in CDKN2A, we all understand this is something which
what about PDL1 more than 50%?
50%. So as we understand, with the patient who are having the actionable alteration in the EGFR, we don't prefer immunotherapy upfront. But on the other hand, the patient also have this cold tumor microenvironment shown by MTAP and CDKN2A, which also again says no to the whole thing. But we'll go to the next question. So we have.
So that's the best advantage, I would say, to the whole public, that when you have that report, simply target testing versus a comprehensive genomic profiling makes that difference.
Makes a difference. So again, interpretation is context dependent. So that is what I wanted to emphasize.
Suppose we had a hotspot testing EGFR exon 20 3 months down the lane. We have given an EGFR exon 20 directed therapy, whatever is the choice of the physician of it, but it hasn't responded. The reason, because there were MTAP loss, there was CDK, and there was TP53, and that's why we have to use a concurrent chemotherapy agent with the EGFR exon 20 insertions.
Exactly. Amivantamab plus chemotherapy will be a better option, not only the amivantamab alone, monotherapy. So there are these minor changes which the guidelines approve both the therapies equally can be really delineated by the report itself. That is the take home which I try to interpret the whole thing. So definitely you can do whatever, but amivantamab already has the action against the EGFR expression or the wild type actually. The mutation is. So not required. Amivantamab can down-regulate the EGFR expression per se. So the wild type also goes down. The mechanism called targocytosis happens where the down-regulation of EGFR goes down. Most of the time it is mutated, so you see the responses. So these are the one this I'm talking about is untreated, first line, upfront actually. Exactly. So we have to again already alluded in few of these slide discussions that there's a unique insertion at exon 20 which we should not miss, where you can give TKIs with confidence actually. Other TKIs beyond amivantamab, and I have enlisted that. It is called location 760 to 764 insertion, FQEA insertion, where the second generation, even the first generation can also work. And also, if somebody cannot afford amivantamab, osimertinib at a higher dose have some responses, so there are some options for the patient. But anyway, let's go into the second case. I already mentioned that the deletion of CDKN2 and MTAP loss is a cold tumor environment. Even if you see PD-L1 50%, immunotherapy may not be the right choice. Interesting case, metastatic CA lung, upfront NGS done, ALK fusion seen, another non-canonical fusion in ALK also observed. So all these are lung cancer complex cases, so just bear with it. But what is the take are we comfortable enough? So we have the variant 3 here, where the response to quizartinib is known to be low already, but definitely alectinib can be offered. But what are the implications of non-canonical on a canonical alteration seen here, actually? Any take? Dr. Vikas, what are you going to do in your clinic if you see this patient? And what are you going to tell them?
So as I see, it is ALK right now, and we have a variant 3. So there is a differential response to the crizotinib.
So the patient says, am I going to do good or bad? Give me a simple answer, yes or no.
Now, if you use a strong ALK inhibitor, where I'm going to push for here right now, so lorlatinib or the third generation upfront, that's where I'm going to say that that response is going to be nullified by the strong inhibitor. So I'm going to push my best gun here, since it is a non-canonical fusion and it's a variant 3 for me.
Okay, so anyway, so the report says whenever we come across complex ALK fusion, they do better. So we don't have to worry about the non-canonical here. The driver is still the ALK, and you're using an ALK kinase inhibitor, it is going to work like a charm. Definitely, you can avoid quizartinib because we are seeing variant 3, but the other generations can still do better. But a quick take home, the interpretation is again context dependent. So the other mutations do play a role in taking that decision. So again, I'm coming back to the same concept of a quick question again, metastatic lung cancer with TMB of 49, MET amplification. What is your choice, immunotherapy or MET inhibitors?
MET amplification.
So you have MET amplification. I can just give a number to it. It's 15 folds. And you can go ahead. 2 or 3 minutes, can I have it? Yeah, please.
Yeah. But here, yeah, TMB is also high, so actually we can go.
Okay, so the TMB was high, but you are seeing CDKN2A loss again. Yeah. Are you comfortable offering patient immunotherapy? But there is no MTAP this time. It is not 9P21. So there may be a variation. So MET amplification is the choice, but normally MET amplified tumor are known to have a hot environment. They tend to have more PD-L1 expression. They tend to respond more to immunotherapy. In this case, I would say, out of box, to combine MET inhibitor with immunotherapy, actually. But that is my personal take, but if somebody wants to debate, I can debate outside. VEGF, I don't see a molecular signatures to address that, but there is, VEGF can be added. It can be done. It can be
I
done.
believe we have a molecular profile that's suggestive of that it's not going to be immunoresponsive except for the tumor mutation burden, which is, I believe...
49 is too high for you to predict the response will be very, very good.
But it is laboratory dependent, individual variant, and
so
again,
the FDA
TMB
approved
is
test
something...
you are talking about, the criteria is well met.
But you have downstream something that's showing that there is a non
So that is the debate we are bringing here today.
We'll start with MET amplification, MET inhibitors, and then in second line, I would say
okay,
that...
so the last case, and then we are done, actually. And you have to help me out here. This is, again, a metastatic lung cancer with a classical RET fusion here. And I'm very happy to see and tell the patient next day that we have RET inhibitor, not in India, but I can get it from the US, elpercatinib, or whatever drug you can, and it is going to respond like charm. So what is the take home? Is it going to work like charm, yes or no?
Yes.
Yes?
Yes.
Vikas, yes or no? Yeah?
Yes, always.
Yes, all 5 of them say yes.
Yeah, red.
So if you see the other alteration called ERRFIU1, that is the ERBB, regulatory inhibitor factor, and this is truncated, which is activating the ERBB2 pathway in parallel, I don't think it is going to work like a charm. So that is the interpretation. We cannot ignore the parallel alteration sitting in a case. We have to dig more and more. So please don't stop if you see your target and start treatment. With that, I thank you very much.
One quick question.
Okay, please. I'm done. Thank you very much. Thank you very much, all my panelists, and for a wonderful discussion and participation, and the audience patiently listening to our cases. Thank you very much.
Thank you, sir. I thank all the panelists. I thank Dr. Aparna for having chaired these sessions. To start with, I call upon our next chairperson, Dr. Dinesh Pendharkar, sir, who is the Director and Senior Consultant, Department of Medical Oncology, Sarvodaya Cancer Institute, Faridabad.
So, good afternoon, everybody. Our next speaker is Dr. Istvan Petak, basically an Hungarian, an oncologist working in the field of precision medicine over 20 years and involved in the development of a special AI program which can really help us in a situation like this. So, we just heard a controversy in the last presentation. Everybody felt that this drug could be recommended, and the author felt that it may not work. These controversies would emerge daily. And my humble request to you, please do not neither ask such questions on the podium, nor give such answers, because we are not computers. Only computers can assist us, because there are so many variations. We are studying 20,000 genes, and everything, every individual, every tumor is different. So unless we make of computers, unless we make use of AI, and we can do co-computing of multiple fusions, we will not be able to treat patients. So here is a presentation on how a 20-year-old program, which was evolved over 20 years, a software, a computing software based on actual patient clinical and genetic data has evolved, and how it can help us in controversies like this. Dr. Istvan, please.
Dear colleagues, Professor Pendharkar, dear organizers, thank you very much for inviting me to contribute to this extremely exciting session on precision oncology. And as Dr. Pendharkar said, I've been fascinated with this idea of precision oncology, which really means to me to treat the patient based on our understanding of the mechanism of the disease, the cause, because history tells us whenever we actually understand the cause of a disease, soon after we find the solution. So we are all enthusiastic about this. And also myself, actually, I sat through 10,000 cases on a molecular tumor board, and we had the same debates we could see this morning when we have multiple genetic alterations, and each genetic alteration can be linked to multiple different treatment options, but each treatment option can be linked to multiple of the genetic alterations present in the same patient. And the challenge is, how do we know if we make the right decision without evidence, without actually clinical trial evidence? So how to combine the concept of precision oncology, which is really the concept of using our logical inference, understanding how that driver alteration actually drives tumor progression and tumor growth, and how we combine this type of logic with the concept of evidence-based medicine we cherished for decades, because we always want to know we do the best for our patients. So that's the challenge, and I think to solve this, we need a new type of category of medical tools. We need medical softwares as a third tool. So we have fantastic molecular diagnostic tests. We have more and more molecularly targeted therapies, and now just simply we have to think about having another tool, another set of medical devices, and I think this will be the mathematical age of medicine and precision oncology. And so why we do we need this? Because there is a huge gap between what we know about cancer and how much we actually use from this knowledge. That we heard this morning that in India, only 10% of patients who actually had an NGS test actually received the targeted therapy, and only 4% actually benefited. So if we compare this to the actually fact that based on whole genome sequencing of tumors, thousands of tumors, in 2020, investigators across 4 continents reported that now we are able to identify the genetic cause of cancer in 95% of cancer patients. So this is really historic. It's the same historic milestone what we achieved when we achieved the completion of the Human Genome Project. Now we are getting to the completion of the Cancer Genome Project. So by now we know that, at least in COSMIC, the cancer gene census counts over 400 cancer genes, and it doesn't seem to be a lot. But still, the problem is it's more than 100. If it's more than 100, the average frequency is less than 1%. So the challenge is, how do we develop the evidence what to do in case of each? And on top of it, we know that each gene, cancer gene, carries different type of mutations, and the type of mutation matters, as we heard this morning. And also, on the top of it, each cancer carries on average 4 or 5 out of these mutations. So that's the challenge. And so the basic concept of precision oncology, I really first faced this dilemma was actually 20 years ago when we had our first lung cancer patient where we detected the EGFR mutation and amplification. And that time was the same year in 2003 when Jeffrey just failed in a phase 3 clinical trial. So we had this dilemma that we had the highest level of evidence that the drug doesn't work, and we had this patient with the amplification and mutation, and in a time when there was not even a case study yet published that would prove a link between the presence of EGFR mutation. What we had to do is just simple logical inference to make the decision. And of course, luckily, we made the right decision, we know now, and the patient had an excellent response. So by 2010, I had the privilege to be an invited author for Nature Reviews the drug discovery, and at that time, we were all enthusiastic that we would have an approved companion diagnostic test biomarker for each targeted therapy, because this was the concept, that we will simply co-develop them and co-register. And I believe that myself as well. But just now, if you look at the number of biomarkers approved by FDA as a companion diagnostic test, we see that it's around 30. And it's really few compared to the number of genes we know, and then compared to the number of targeted therapy. So the reason is, of course, is a mathematical reason, that only a fraction of patients, as we see this morning, actually harbor a single actionable mutation we can easily target and achieve a good response. Majority of our patients, as we could see, have a combination of these alterations. And actually, I made this fun calculation, how much time we would need to generate evidence, clinical trial evidence, what to do in case of each combination of mutations, and the answer is 14.4 million years. So we really need an out-of-the-box solution if we want to practice molecular profile-based medicine and based on evidence-based medicine. So another example, this was really, I can skip this slide because it was heavily discussed this morning, that what do we do when we have multiple actionable mutations? For example, a breast cancer case where we have an HER2, ERB2 tyrosine kinase activating mutation, but at the same time the patient is a BRCA mutant. So we all know what to do in case of each of these alterations, but what do we know in the presence of the combination of this? We need a clinical trial. We have to compare PARP inhibitors to HER2 inhibitors in patients who have both. Easy answer.
But then this patient also had that MYC amplification. So then we have to do another clinical trial that then we include the CMYC amplification. So that's on and on and on. So we cannot do this. So the solution, just jump to the point, is to really create a computational model, a computational reasoning platform that mimics our logic, our human logic, how we make inferences based on our understanding the functionality of these genes. So, this is what we developed based on 10,000 cases where we created connections between genes and targets and compounds based on published evidence. So this model was not built on trained on machine learning, because that's the number of variables is so high, the dimensionality is so high that you machine learning to develop a model that can be used to predict multiple therapies is not possible yet. We will need millions of patients' data to do that. It's possible to use machine learning algorithms to recognize patterns that enrich patients who benefit from one therapy, but to create a model that mimics reasoning and predicts a response to multiple targeted therapies is not possible yet. But this is what we need if we want to practice precision oncology. Because if you just generate a new type of biomarker, an algorithmic biomarker, to predict one therapy, we have the same dilemma again, what to do if we have both. So we need a model that predicts to multiple. So this is what we have accomplished, and now the model is ready. It can be used in clinical practice, and so we can use it with any type of molecular diagnostic test results, both also with liquid biopsy test results or different panels, in combination with other type of tests, single gene test, immunohistochemistry, FISH. So whatever, we took in the totality of the molecular information we know about the patient. These are standard tests already available, and the model will generate a predictive score to multiple hundreds or thousands of targeted therapies. So again, just to make sure that it's clear, we are not linking one genetic alteration to one treatment option at a time that standard reports do. We combine everything in the model to come up with a ranking of therapies based on the generated predictive score. Of course, the question is, does it work? This is what we have to answer. We believe that this will be a new category of tools, and the American Medical Association recognized this last year and created a new code, actually. Oncologists will be able to use to get reimbursement for using a tool like this. They call it pharmaco-oncologic algorithmic treatment ranking. We have to practice a little bit, but basically the idea is to have a new type of method we use in clinical practice. And our job is to create the tools our fellow oncologists can use. So in this case, the input is the result of a standard report, and the output is the algorithmic treatment ranking that creates an objective, supports our objective decision between treatment options in cases of multiple genetic alterations we see. We have also saw this morning in those cases. So, of course, if this is a computational tool, if this is a software, the nice thing about it is that if we give the same input, we get the same output. So it's possible to actually validate the performance of such new tool. And this is what we did based on the SHIVA-01 clinical trial. That was the most important one and the first one. And in the SHIVA-01, that was the first randomized precision oncology trial. And in this clinical trial, all patients received a matching therapy based on a predefined molecular biomarker. So each patient received a matching therapy, yet the model could separate patients who really benefited from molecularly matching therapy to those who didn't. And we could reproduce this also in a real world. Now we are getting more and more data where we reproduce these results also in partner cancer centers, that we can improve disease control rates by 70% in cases where 39 different drugs were used. So again, also here is not the result of one treatment. This is the result of 11 treatments used individually. And here is 39 treatments used in the average outcome. And the same, and this is the most astonishing result we just got in lung cancer, in a cancer center where 15 different drugs were used, that we could actually triple the survival in lung cancer. So this is ready, and we are welcome fellow oncologist colleagues to try and explore this new era of algorithmic medicine or mathematical medicine. And with this, thank you very much for your kind attention.
Can I ask a quick question?
Sure.
When you're inputting the report, is that the PDF or is that the raw file?
We can start from the PDF. Of course, then we have to. So you only have to upload in our secured portal the PDF report, and then you get back our report.
You see, because when you're really talking about interactions of various molecules at some level, therefore to predict what are the drugs that are likely to work, there will be enough allele frequencies which are below the threshold of each company. Foundation and Caris, and they themselves have different thresholds. So it would logically make sense to put in the whole raw data there and then come up with interaction and pick up the top interaction and top therapeutic response there.
You're absolutely right. So we are looking for partner laboratories where we can collaborate on receiving the raw data and control the whole bioinformatical pipeline to standardize the input. You are absolutely right. So far, what we can see that the model is quite robust and can improve treatment decisions based on different type of diagnostic tests. So I think simply moving from single biomarker-based decision to taking into account the possible biological effect of the other co-occurring 3-4 creates such an improvement in our ability to predict that's really clinically useful. But you are absolutely right. If we want to develop this into a model where we can predict an absolute benefit for each drug, we have to standardize the input. Absolutely.
To continue on Dr. Nitesh's question, since you are looking at all the interactions and pathways, is it not logical to think that a whole exome sequencing and then the raw data input would be probably or even a whole genome sequencing, and then including everything will be because that's the magnitude you want to say, that you want to capture everything, put everything together, and that's where the computational power comes. And so what sort of data is put inside is going to give us what is the result. So that is extension of his question, but I have a different question.
Sure.
Not only your organization, there are quite a few others who are now doing this bioinformatics crunching, and they are coming out with pathway analysis, and then they are beginning to recommend the treatment based on algorithms and software. So when we ask them what software is this and all, each one have their own proprietary software. Then the question to them is that, is any of their software validated, and by validated by whom? There seems to be no answer there. So we just have to look at the banner and trustworthiness, and then is there a way where your community has a way to know whether this particular software crunching is validated beyond? What do you do for that kind of answer?
Yeah, so I think it's an emerging field, and I was fascinated by a paper actually written by two excellent oncologists in NIH in 2019 and about the future of precision medicine. And so they vision that in 2039, there is a patient who enters into a randomized clinical trial. But in that clinical trial, the question is not which therapy is better. So the trial doesn't compare two drugs. The trial will compare two AI-guided drug assignment algorithm. So you will see randomized clinical trials again, but between software solutions. So evidence medicine will come back again. It's just we test different tools. And you're absolutely right. This is the future we have to embrace. And I'm very excited to see which algorithm is better in which setting, in which indication. Probably there will be differences. And it's an exciting new time for us to explore. Yeah.
Check with the Shiva trial, but Shiva trial in general was, for precision medicine, it was a negative outcome. So I was just wondering that what was the outcome based on your Genomate? There appeared to be like 70% you predicted them to be on treatment, or there would be a response based on. So were the treatment predicted by the Genomate was comparable to what was offered in the Shiva trial? Because Shiva trial had its own limitations.
Is it?
You're around, right?
Yes, I'm available, so I'm happy to answer.
A coffee between both of you is on me, downstairs. I'm so sorry.
That's
We will
okay.
have to cut this.
Thank you. Thank you, sir. Thank you so much.
Next to talk upon the advances in artificial intelligence in precision oncology, I call upon the moderator, Dr. Nitish Rohtagi sir, Senior Director, Medical Oncology, Fortis, Gurgaon.
Thank you. So while we were organizing this, we did think that artificial intelligence will become very critical to genome sequencing and precision medicine, and that's why two back-to-back talks in some ways, although they're not exactly the same, I can tell you that. So with that, I actually invite Dr. Andrew Palmo. He's the Director of Medical Affairs at Tempus. For those who know Tempus for a while, I've been following them for many years. They have always tried to be slightly ahead of the curve by putting some level of algorithm and bioinformatics there. So Dr. Andrew, without further ado, over to you, please.
That's better. Thank you. Good afternoon to you all. It's a pleasure to be here. And I think it's an interesting follow-on that you've put these two presentations together, and I'm sure you and I will have something to talk about later. Well, with the coffee group downstairs, perhaps. So let's look at Tempus. Tempus is a data company, an AI company, but you'll probably know them more actually as a genomic sequencing company. But this is what Tempus was set up with, the vision of taking all the information that we generate about patients through their diagnostic journey to try and unify it into one place to then enable clinicians to put it into their workflow and make better informed treatment decisions. So Tempus has been working on this for about 10 years now. And we've got various algorithms and new ways of working with data which are already in clinical practice. And I'm going to share some of those with you, but I'm also going to just highlight the value of combining molecular and clinical data. This is a publication in Nature Biotechnology that showed that combination actually improves the matching of therapeutic interventions. So it's using the data in combination that generates the value. So no one piece of information is generating everything. And obviously, if you're familiar with NGS testing, it really is the case for me to make that we offer a comprehensive genomic profile. But the reason we do this, the reason that it's designed the way that it is to make it as actionable as possible. And the tests are combined and offered to deliver on that goal. Those are along the top of the slide. Along the bottom, this is where we start using some of our data and integrating that with our molecular results. Obviously, the uniqueness of the Tempus testing is we use multi-testing modalities in one testing form, which then enables us to do pharmacogenomic testing without additional tissue requirements. But we've also got AI-driven algorithms. So these are based on the large database that Tempus has now amassed, and we're at about 7 million de-identified patient records as of today. And we've used that data to develop and validate new algorithms such as HRD or tumor origin. And obviously having the information gives us some key advantages in clinical practice. I've talked about the tumor normal match, which is a technique which isn't widely available by everyone offering NGS profiling, and I'll give you a reason why that's clinically useful. I'll also talk about whole transcriptome RNA sequencing, which again is offered routinely with Tempus testing. There's some other practical components that help deliver those actionable mutations, and that's the option to automatically convert to liquid biopsy when tissue fails. And I think we've already talked about today concurrent and longitudinal testing, so I won't touch on that very much. So let's just quickly recap why the tumor normal match is such an important approach. The schematic that we're looking at on the left of the slide just gives us a nice illustration of, if we only look in the tumor, in this particular case, we seem to pick up 2 variants. If we'd actually tested the blood as well, we would learn that that's a potential germline finding, and we'd be able to subtract that from our somatic finding and then increase the true call for that somatic finding. And that's why at the moment we're using somatic NGS testing. So we don't really want to find potential germline findings if we're looking about treatment management of metastatic disease. So having that combination enables us to do that. And I think also we know that certain tumor types are guideline recommendations for hereditary cancer testing. Obviously, this approach where you use tumor normal match, you can actually then identify potential germline findings in those patients who don't have hereditary testing. And that's an indicator to say perhaps they should use a validated germline test to confirm that potential germline finding. So let's look at a case study of using this technique of using both tumor normal match. So this is actually a really interesting one. It's 2 real case studies from the Tempus database, obviously anonymized. They're related. So it's lung adenocarcinoma. There's a family history, so they're sisters. So this is the first sister that was tested. And on this particular occasion, the normal match wasn't actually sent. So we only did the somatic DNA reporting, and you can see the 2 somatic ATM mutations that were discovered. However, her sister also, unfortunately, had lung adenocarcinoma. But at the time of ordering, she both had the DNA test and the tumor normal match. And we can actually see in this particular case that ATM mutation was actually a potential germline finding. So that true somatic finding was the KRAS mutation, and that impacted how the patient was managed. I'm going to move on to another concept which may not be broadly adopted, but again, within the Tempus testing portfolio, we're trying to drive actionability of the testing and make sure that the samples that we're sent, we test to the greatest ability. Along the top of the slide, we've got 2 independent publications that look at driver-negative lung cancer cases where the DNA cases weren't able to find anything, whereas when the RNA was completed in those same patients, we actually found that they were driver positive. And then if we look below the 2 publications, we can see some of the reasons why that may be the case. So obviously, as we learned again earlier on this morning, there are pros and cons of the sequencing technology that we could employ. So being aware of those limitations perhaps can guide which tests we use and when. So obviously, if we've got large introns, then DNA may not be so good because you need quite excessive sequencing, but RNA is pretty good at capturing those. Repetitive introns are also quite difficult for DNA because the reads can't be aligned. And sometimes, not in all cases, if you've got low, the DNA's that result is below the assay sensitivity, it still may be picked up using RNA. And then obviously complex genomic events can also be missed by DNA, but again can be captured by RNA. And this is just some practical clinical application of those findings. In another clinical research, a separate clinical study, that looked at patients that found relevant RNA-identified fusions and then followed them up to see what therapies that they were actually assigned. And we can see if they had an actionable fusion with a matched therapy, then this improved their outcomes. So again, in combination, it's important information to have access to. This is a bit more data from the Tempus database. And this is looking at patients that have both RNA and DNA sequencing. And it improves the clinical actionability, which is what we're trying to achieve here. So on the left-hand side, the gray bar are all the actionable mutations. And we can see in the right bar, of those that were identified and actionable, they can be split out by those that were in the dark blue, found by both testing modalities, versus the purple, which was detected by RNA only. And then if we look to the right, we can see the distribution of fusions found by disease type. So let's look at that, another case study with both RNA and DNA testing. And what happens with testing at Tempus is that we test these in sequence. So we'll always do the DNA first, so that report will be delivered first, and then we will continue doing the rest of the sequencing. And on this particular occasion, there were no real actionable mutations found in the DNA sequence. So we proceeded to do the whole transcriptome sequence, and this is where we found an actionable fusion, which had a number of recommended therapies that both had FDA recommendations mentioned in the NCCN guidelines and also OncoKB tags. So again, the clinical implication of trying to generate as much actionable information as possible from the samples that are being used is key, a key endeavor. Now, it's all well and good having isolated reports about patients and the genomic information that you have. Obviously, Tempus being a data company, we actually share this with you through our hub. And this is an online portal where you can see all of the orders that you process for your patients. And also, if you provide additional clinical information, you can actually get patients that match within our database that have a similar profile, and you can see how they potentially were treated and what their outcomes were. You also have the ability to search through your own clinical practice and see the patterns of variants that are detected. So it's quite a good audit tool. And it also goes without saying, it has a virtual assistant called Tempus One, so you can interact with it orally and ask it questions to surface the data and the patients you're interested in. So speeding up your time when you're with your patients in clinic. Tempus is all about collaboration. And we haven't really achieved the large database in the US and the algorithmic development that we're focused on without collaboration. And we're always looking for new collaborations to help bring the benefits of precision medicine to wider groups. So that's just the beginning of what Tempus does. I had a very tight brief, and I didn't want to go over that tight brief. But I think you saw from the very first slide that having that unified database called the Tempus OS is a very powerful tool. And in the future, there's going to be a lot more things that we can do with it in terms of patient management, making sure that they stay on track on their patient pathways. So come and visit tempus.com and have a look for yourself. And also come and find me in the breaks, and we can have a conversation about what collaborations may be available.
Thank you, Doctor. Really brilliant, so simple. Any burning questions in the house? We'll have time for one question, and please, yeah.
Yeah, that was a nice presentation, I'm an imaging scientist. I just want to know, this is basically, related to genomic, analysis. Is there a possibility imaging analysis can be integrated and how it can be developed?
Sorry, I didn't hear the question.
I mean, this is basically, NGS, genomic-based, analysis. Is there a possibility where imaging analysis can be integrated? If there is a possibility, how?
Yeah, I've only actually talked about the NGS component, but we also do image analysis for both pathological slides and radiographic imaging. So all of that data is now being combined. So we have a multimodal database, which we're now combining to develop algorithms that can go across those modalities and find key insights.
Thank you.
I think my overall take on what I've heard is that this is certainly something which is not heading towards a report alone, whichever way we look at it. It is going to be a test, the analysis, your analysis of the findings, and then there's another layer which is going to be thrown in eventually, whether that's AI-driven or not, but there will be another layer of the clinical impact and the clinical usability of that.
Exactly.
Amazing talk, very exciting. I think he asked about when are you going to integrate your AI-based analysis into your reporting? That's his question. But my question to you is that in what you showed, a common fusion like an EML ALK was missed by the DNA sequencing and was picked up by the RNA sequencing. So why should that be? That's one question. But then we know what Tempus is doing with versatility. I want to understand whether you are at present only reporting the RNA sequencing, or are you going beyond that and doing RNA functionality of RNA action? I mean, are you still there, or are you reporting on that? You are definitely having it in your lab. We kind of know that, but are you reporting it now?
Yeah. Okay, so there are a couple of questions there. So the first one, obviously, we all know, because of the slide I've just shown you, about some of the limitations with DNA sequencing looking for fusions. And I think it also depends on the signature that you're being used and how many probes have been selected specifically looking for those fusions. Now, RNA is a whole transcriptome, so everything gets transcribed is reported. So that's the value of doing it. So potentially it's limitless, potentially. Now, the other thing about using other information from RNA analysis, so RNA expressions and things like that, that is presented in the Tempus hub. So what we try and distinguish is what is analytically and clinically validated. So the RNA assay is clinically validated for fusion calling and splice variants. The RNA expression is analytically validated, but not necessarily clinically validated at this stage. So it's available in the hub, but there is that designation that there's no real clinical validation for it. So it's surfaced, but it's used for research purposes and with clinical judgment.
That's very relevant, actually. Thank you. Thank you.
Thank you. My pleasure.
Thank you, Dr. Nitesha, and thank you, Dr. Andrew Paramo. Now to call upon our next speaker, Dr. Sai Vivek sir, who is a consultant, Department of Medical Oncology, Aster Hospitals, Bangalore, to talk about Lynparza in the maintenance management of newly diagnosed ovarian cancer.
Good afternoon, everyone. I think this is going to be like a palate cleanser to the last few hours of precision oncology, from a lot of unknown to something known. So I'll quickly run through it. Most of us are aware of this data, and I would like to thank the organizers for this opportunity. So we would be covering the topic in these 4 subheadings. And as we all know, there is a significant unmet need in carcinoma ovary, where the median PFS for most of our patients few years back was only around 14 to 18 months, and with 70% of them progressing within that time period. And the 5-year overall survival was only around 30 to 38%, even though we diagnosed them in stage 2 or stage 3 also. So this is a typical progression of any CA ovary. We get a good PFS in the first line setting, around 14 to 18 months, and then starts our multiple episodes of recurrences, actually. So second line, third line, as we go along, we get a few months with different lines of therapy we try, but in the end, the patient always goes into bowel obstruction and nutritional detriment, and then we tend to lose the patient. So this was the course of the patient with CA ovary until around 2015 and 2016, and then probably with the advent of more and more precision medicine, we are able to pick up somatic, germline, and now HRD in CA ovary. So testing for BRCA and CA ovary gives us 3 important values. 1, predictive. We know that they will be both platinum sensitive and sensitive to PARP inhibitors. Prognostic, people with BRCA mutation or HRD positivity tend to do well than the non-HRD or BRCA. And risk assessment, it can help us identify other family members also who could be tested and then given preventive strategies to prevent the occurrence of CA breast or CA ovary. But one thing, if you go by the traditional means of just going by family history, we are going to miss around 47 to 48%. And if we just go by younger age, being more associated with genetic mutations, we are going to miss as much as 70%. So just going by clinical history, and especially in a country like ours, where history is hard to come by, most of them wouldn't know what happened 20 to 30 years back. Just going by the clinical parameters is not sufficient anymore. So that brings us to what the guidelines say. Whichever country we look at, they say in the upfront setting, at the time of diagnosis, that would be the best time to test for BRCA or rather HRD nowadays. So how do we test it? We can either test it in the blood, that is the germline, that is then we look at the tissue, which is the somatic. HRD is basically the phenotype. Testing either in the germline or somatic is the genotype, and HRD becomes the phenotype. The presence of all these genetic mutations will give the cell the phenotype of being HRD positive or HRD negative. So with just germline and somatic, as I was mentioning, we are going to pick up only 30% of the people who would actually benefit from PARP inhibition. But with the advent of HRD, that has gone up to almost 50%. So we know that 1 in 2 ovarian cancer patients might be HRD positive, might benefit from PARP inhibitors, and might have a longer PFS and hence longer overall survival, which has been given to us by phase 3 data. So how do you interpret the report? You should be very careful here. So we do have class 1 to class 5. Class 4 and class 5 are the ones that we have to concentrate on. Class 4 is likely pathogenic, and class 5 is definitely pathogenic. These are the only 2 class of patients who would actually benefit from treatment. So class 3, class 2, class 1, not of interest at this point. So class 4 and class 5 in the report is when we start our actionability. So we cannot make a decision just on a VUS. We know that from the last few hours, and we should be aware that the VUS status keeps getting updated. And right now, I don't know who the onus is on, whether the clinician or the lab, to update the patient, but I think it has to be a team effort, and both the physicians and the testing laboratories to take it upon themselves to intimate the patient and the clinician that the status of that variation of unknown significance has changed to either likely pathogenic or pathogenic. So this is again a reiteration of that. Where we are interested in is the presence of pathogenic or likely pathogenic BRCA1 and BRCA2 mutations. So the takeaway messages from the testing point of view, test all. In the upfront setting, whenever sufficient tissue is available, HRD is the way to go at this point. And coming to the 2 trials quickly, one is the SOLO one and the PAULA one. So olaparib maintenance treatment has been investigated in these 2 trials. And moving on to SOLO, it was a game changer, as I would put it, in the treatment of CA ovary. It was mainly done in stage 3, stage 4 serous or endometrioid ovarian primary or peritoneal or fallopian tube cancer. Patients ought to have had a germline or a somatic BRCA mutation post a cytoreductive surgery in clinical complete response, a partial response after platinum-based chemotherapy. Patients were randomized in a 2:1 fashion to olaparib 300 milligrams BD or placebo. This was for 2 years of duration. The primary endpoint was PFS, secondary endpoint was PFS2 and overall survival, and PFS using BICR. So one thing to note here is many of the patients had a good response, a clinical complete response after platinum-based therapy in both the arms, and the primary tumor location was in ovary, and most of the patients were in stage 3. So here, as we see, almost 2/3 of the patients underwent an upfront surgery. So even though they would have been in stage 3, most of them did not have those high-risk factors which pushed them into neoadjuvant chemo, followed by surgery. Most of them were being operated upfront. So 2/3 had an upfront surgery, and 36% underwent a interval cytoreductive surgery. And almost 40% to 50% of them completed the 2 years of olaparib. Olaparib is a game-changing drug, but not an easy drug to use. And as we can see here, 42% discontinued before 2 years, and 47% completed the treatment as per protocol. So the side effects of olaparib, all of us have experienced them: anemia, fatigability, and patients do complain. This is the adjuvant setting, and first-line maintenance in a patient who has undergone a major surgery and chemotherapy, that is what would have resulted them to have side effects and discontinue treatment before 2 years. But this was never seen in CA ovary treatment. As we see here in the 60 months and the longer follow-up, the PFS at 5 years was more than double at 21% versus 48% in the patients receiving the 2 years of olaparib. The median PFS was 13 versus 56 months. The hazard ratio of 0.33, that was something which is very rarely seen in medical oncology. Nowadays, it's coming up more often, but this was the initial trial which showed a hazard of 0.33, showing a 77% reduction in the hazard of progression in patients who received olaparib for 2 years of duration. PFS2, which is the time from randomization to the second progression, again, was not reached in the olaparib arm, and it was 42 months in the patients in the placebo arm. The overall survival at 7 years, as we see, it wasn't reached in the olaparib arm, and it was 75.2 months in the placebo arm with a hazard of 0.55, very significant, and 44.3% of the patients in the placebo group received subsequent PARP inhibitors. In spite of that, we see a great magnitude of benefit with a hazard of 0.55. The adverse events in the SOLO trial, we are aware of them now. Anemia is the major contributing factor, followed by fatigability, neutropenia to a certain extent. And anemia, if well managed, most of the patients we know do come back early to us in the initial few months with their hemoglobin report. That is the time in clinical practice and in some real-world studies, testing for simple vitamin B12 becomes an important factor. Most of them would have a vitamin B12 deficiency because of nutritional issues in our country, and just correcting that would help us maintain the dose of olaparib also. So take away from SOLO, a great reduction in progression and an overall survival benefit, which is significant, makes olaparib a game changer in a germline or a somatic BRCA mutated patient. So moving on to POLA1. So this was again stage 3, stage 4 high-grade serous ovarian cancer, surgery done, and received platinum or taxane-based chemotherapy and at least 3 or more cycles of bevacizumab. Here again, patients were randomized in a 2:1 fashion to olaparib plus bevacizumab versus bevacizumab alone. So at this point, before the PARP inhibitors came, in a patient with stage 3 or even stage 4 with incomplete cytoreduction, bevacizumab maintenance for a year was the standard of care. That added only around 4 to 5 months at the maximum to the PFS. So now with the addition of olaparib, this was started, and here they didn't have an upfront necessity to have a BRCA mutation. So this was the trial, and as we see here, the primary endpoint was PFS, and both the arms were again well matched. Here, 50% of them underwent upfront surgery and 42 interval, and most of them had response to platinum. So if we see the curves here in the patients in the PFS, and here we see that the median PFS in the intention to treat population in the olaparib plus bevacizumab arm was 22 months versus 16.6 in the placebo plus bevacizumab, which is almost close to what we would have seen if we had just given bevacizumab post our surgery pre-2016 and 17. So addition of olaparib was significant. It was 22.1 months, and in the median PFS versus 16.6. So in the subgroup analysis, what I would like to concentrate upon is almost all the subgroups responded to the treatment with olaparib and bevacizumab. But if we go here and then post hoc what they did, so the POLA-1 trial, approximately 50% of the patients were HRD positive. So in the HRD positive, so we see that 29% had a tumor BRCA mutation positivity. So when you get a HRD report, they do give you the BRCA1, BRCA2, and the genomic score. So BRCA1, BRCA2 is indicated as part of the HRD report. So 29% of them had tumor BRCA, and 19% of them had a genomic instability score more than 42 in the Myriad lab, which put it at 48%. So if we see here, tumor BRCA mutated patients had the best response, followed by, or equally matched with HRD positivity, and HRD negative or unknown is the people who derived a very small benefit or something where we can dissect upon much more whether to actually offer them a PARP inhibitor. But tumor BRCA mutated or germline BRCA mutated, going back to the SOLO-1 trial, and HRD positive, these three subsets of people should be put on a PARP inhibitor post our first-line treatment. So the non-BRCA mutated patients, as I was saying, the magnitude of benefit is not that much. The hazard is close to 1. It's 36.5 versus 32.6 if you're talking about the PFS. And this is the set of patients where the treating clinician could take a call on his discretion. So overall, HRD positive and BRCA mutation are the people who respond to PARP inhibitor maintenance and have a significant magnitude of benefit in terms of both PFS and overall survival rate. So at 5 years, 65.5% of the patients receiving olaparib and bevacizumab were still alive versus 48. So the overall survival benefit was there at 0.45. The hazard ratio of 0.62, but probably in the intention to treat population, this was driven by the 50% of the people who were actually HRD positive. So again, if we break it down to BRCA mutated, HRD positive, and HRD negative, the curves actually are very close and almost crossover in the HRD negative, but definitely a good magnitude of benefit in BRCA mutated or HRD positive. The adverse events, they were consistent with what we knew with the side effects of olaparib and bevacizumab, no new red flags, and majority of them, because of the addition of bevacizumab, had some evidence of hypertension and proteinuria, along with anemia, fatigability, and other side effects of olaparib. So we have dissected this more and more, but one important take-home message is around 1 to 1.5% of the people with PARP inhibitors carry a risk of MDS. So keeping that in mind for a clinician and then checking for it, I have not seen it, luckily, so hopefully I never see it also, but that risk is always there for a patient on PARP inhibitor. So quality of life, definitely not too bad compared to just placebo plus bevacizumab. It matches with the quality of life, but it requires some hand-holding in the initial few months of usage of PARP inhibitors. So takeaway messages, combining both solo and POLA1, I think HRD positive or even just germline or tumor BRCA mutated patients derive a significant benefit from usage of PARP inhibitors, and testing for HRD or whatever we are testing should happen in the upfront setting when we initially diagnose our patient with CA ovary. Thank you.
Thank you, sir. I call upon our next speaker, Dr. Amit Bhargava, Senior Consultant, Department of Medical Oncology, Fortis Hospitals, Delhi, to speak about use of off-label drugs in Indian setting.
Good afternoon, everyone. While we were discussing all these things, so I thought, prescription of off-label drugs is also a very important part in precision oncology. As we just saw, there were so many mutations, every mutation having a reaction with each other, the drug getting altered in the presence or the absence of mutations. And we cannot have randomized clinical trials for every clinical situation. Oh, this is not my presentation. The other one, Simon, the one which I mailed in the morning. This is not. So, before I get my slides on, can I have some show of hands? How many of some stupid questions that I'll be asking before I start? How many of us believe in oncology? I guess everyone. How many of us believe in our drugs that we use? Everyone. How many of us have used an off-label drug on a daily basis? Every day, I think so. Under your care using a off-label drug. I guess every one of us use it, And we have some international faculty as well. So can I just know what all countries do you have a proper formulated off-label committee? You have an off-label committee? Anyone else from outside India? Dr. Sai from Dubai, is he still here or left? Good. So, I collected few data and I found, I'll just talk about it later. So, my agenda for today is talking on off-label drugs in our settings, especially taking India as one of the parameters. So, what is off-label prescription? It's prescribing drugs which are approved for some other indications, then you prescribe it for. So this is a very common practice that we have seen, especially in oncology. And while I was preparing this presentation, I had a chance to meet our DCGI, who's Dr. Rajiv Singh Raghuvanshi, and I just put him a question. Sir, do we have anything, formal way of writing and getting a immunity for off-label drug prescriptions? His reaction was very casual, and he said, Doc Saab, almost 90% of the prescriptions in our country are off-label. So I was really shocked the way the authorities are taking, medical profession in our country. So this was an eye-opener for me, but I said, is there a way we can formulate it, because there is a need for offering off-label prescriptions. You cannot have randomized clinical trial or evidence for every possible clinical situation that you face. You have to have some kind of your clinical expertise with whatever resources you are available with to treat a particular situation. So is it legal in India? From an individual desk, yes? Yeah.
Something that's going on out now, and also what's happening in India. We know that antimicrobial resistance is a huge problem, and 70% of the antibiotics that are being used with animals and plants.
Correct.
So there is a move now which the government of India is putting up that every time an antibiotic is prescribed, the indication should be written so that doctors at least think.
Correct.
Don't write viral infection and then prescribe an antibiotic.
See, but the point is, if that indication is written on your prescription and that indication is not written on the drug prescription or the evidence from which it is used, you will be penalized for that. You do not have an immunity just by writing the indication of that drug. So, is it legal in India? As of now, no. If it is coming from an individual desk, the off-label prescription is definitely not legal. If the patient goes to the court or the patient realizes that, my doctor has given me an off-label drug without taking my consent or without informing me, the doctor will be penalized. You have no immunity on this. No insurance can save you. Some way outs, even if it is coming out from a multidisciplinary team approach. You have a tumor board, you have a review board in your hospital, that allows you a partial safety. That it doesn't give you a complete safety like if you are writing an indicated drug, because the Supreme Court tells us that any failure on a doctor's part is not negligence. So we are bound to fail with our treatment. That is not punishable. But if you fail with an off-label drug, that is punishable. No. If you do it in a clinical trial, then it has to be a different setting altogether. You have to take DCGI's permission. There are, you have to follow all those, rules bound by the Helsinki regulations. So that all you have to go through if you are going through in a clinical trial. So if you have a SOP in the hospital, or if you have a multidisciplinary or a review board, you present your case in the hospital and you have a kind of a tumor board, and that drug comes out of a tumor board, that also gives you a partial safety. DCGI does not permit any off-label prescriptions. That is a big irony. We said, now with the increasing evidence in oncology, especially precision oncology, we are having a lot of need to give off-label prescriptions. And we have seen in literatures and data, there are small data published also where off-label drugs have worked. So I gave the example in one of my patients. 6 months back, I had a patient with CA colon, which failed first 2 lines of therapy. We got a NGS panel done, and to my surprise, I got a FLT3 mutation. And when I discussed with my geneticists, they said, this could be a driver. So I put them on an FLT3 inhibitor, and to my surprise, 6 weeks, there was more than 50% reduction in the disease. So this example, I gave it to the Dr. Rajiv, and he said, see, as long as the patient doesn't report it, you can do it. We'll put a blind eye to it. So that is how things are moving here. So it's our collective responsibility to collect data for off-label, publish a paper, get up some evidence. DCGI only requires data of 50 patients to give you an approval for that particular indication. So how do we handle oncology with all these evidences that we have been discussing since morning? So how does it happen in other countries? So let me, before I come for some opinion or something that I have formed for our country, how does it happen in other countries? Of course, by the time all the randomized clinical trials come, most likely our great-grandchildren would be practicing oncology, right? So first thing we can do is we can have review boards in our hospital. We can form a committee of selected senior physicians and surgeons in our hospital. We can, that is how it happens. Then many countries have an off-label committee. What does an off-label committee comprise of? Off-label committee is mostly formed by authorities or the government departments or health departments, wherein they involve the experts of each and every field where the case has been discussed. They have all the specialists from each part of the medical panel. They have private practitioners along with it, and they have biologists and scientists which take part in this, along with it, the authorities which stamp whether you can do it or no. So, yeah. Correct. In our healthcare ministry, there is a provision for pandemics. The guidelines for pandemics are entirely different for what is in a regular or I would say, not emergent situations. Oncology is not a pandemic. So for COVID, there were all provisions, whatever you do is right. Even in COVID, a lot of people practice so many medicines. We all know, as oncologists, even I have managed COVID. Dr. Nitish has managed so many COVIDs. Correct. See, I agree, but the government doesn't take it that way. Unfortunately, we as medicos and the authorities, we go in the opposite directions. For us, the priorities are different. For authorities, the priorities are different. We are looking at kind of, molecular level. They are looking at a cellular level. So that is the difference. So, and the best part is, when I visited few of the countries and I had a chance to listen to how the off-label committee works, the best part was even the authorities there, they were able to look at the scientific basis of what you are thinking. And if you're able to convince them scientifically, even without any evidence or even without phase 1 or phase 2 trials, they would give you an approval. Recently, I saw a patient from Turkey, wherein it was CA gallbladder with cholangiocarcinoma along with it, and with some mutations. So it was IDH mutation, I guess. And they used one of the drugs, ivermectin, and the patient lived for almost 4 years. And that they got approval through the off-label committee. And they had like the way we issue a tumor board number, there was an off-label committee number stamped on that thing. So with the current scenario and with everything happening in our country, how can we go about to have a kind of a safety which can be provided with us? So it is a teamwork kind of a thing that should happen. Do we have off-label committees as of now? No. So there was something then, when I got disappointed with DCGI, I went to NMC. And I had word with the National Medical Council authorities. And they showed me, a door. They said that since 2004, we have been fighting with DCGI to give us an approval. So there were some letters, and I found some pictures of the letters. Indian Medical Council wants off-label prescriptions. So this was the first time when they represented themselves in DCGI in 2004, because there was a big need, not only in oncology, but other specialties also. Even then, they said they also gave them a full proof, regulations that how you can regulate the use of off-label drugs and how we can actually prevent mishappenings. Because if you allow off-label use, there will be a lot of mishaps and misuse of those drugs. So there were regulations where they gave it to DCGI that this can happen. Now, what I gathered from all these discussions with NMC and DCGI members, and what I formulated just few points, which tells us that how we can have a kind of a partial immunity after prescribing off-label drugs. So what can we do? We can create department SOPs. So we need to go to our hospital authorities to form a standard operating procedure for prescribing old is off-label drugs. So you need to have proper, wherein what all kind of patients will be included, what type of drugs will you be using, are these drugs having any very severe adverse effect in a particular disease where they have been approved, how long these drugs have been in use in the market. You cannot use an off-label drug which has just got a FDA approval yesterday, and you cannot use it on an off-label. So there was few provisions that, or the literatures that I read. Create a review board or a tumor board, and that should include a member from DCGI. There is a group of 34 members of DCGI in India who are willing to participate in your tumor boards either online or offline. So of course there are charges for that, but if any particular case is there, they have a provision which they started in 2018, but till date no services have been used. So that is what I got a feedback from Dr. Rajiv Raghuvanshi. From an old committee, that is off-label drug committee, form up now. You can form your own off-label committee within the hospital. There can be senior members. Every hospital has some doctors from who have been working with government institutions, so that is very important. So if you have any doctor who has worked for more than 5 years in a government institution, they can lead the off-label committee drug. So that's also one of the provisions. Special consent form should be there for the patients. And the way you record a consent, that is audiovisual consents, in patients when you conduct a clinical trial. In a similar manner, you should take a consent for prescribing off-label drugs. Include a pharmacologist, basic scientists, cancer biologists in your panel who can give you a complete justification of use of off-label drugs. Try to procure any data available for the same. Even a phase 1 or a phase 2 data available for that particular use should suffice to give you a partial safety in these kind of situations. And most important, the hospital should provide an umbrella insurance cover for this. So there should be a provision that in case if anyone gets caught, just 2 minutes, you should have an insurance for this, and it should be the committee that has to be insured, not the particular doctor. So with this, I thank all of you and wishing you all to be lucky and good oncologists. Thank you so much.
Thank you, sir. Next, we have a panel discussion with the Molecular Tumor Board about interesting case studies in precision oncology and NGS. I call upon our session expert and speaker, Dr. Anita Ramesh, who's the HOD and Professor, Department of Medical Oncology, Apollo Specialty Hospitals, Chennai. I request the panelists to occupy the chair, Dr. Avinash CB, Dr. Mansi Khanderia, Dr. Nidhi Tandon, Dr. Nitesh Rotagi, sir, Dr. Amit Dutt, Dr. Ankur Bail, sir, and Dr. Niti Raizada, ma'am, should be joining us in some. Is more session. And so is Nidhi, ma'am, so she.
A very good afternoon to everybody, and I think sound is there, or I need. Hello, can you hear me? Yes. Hello, hello. Hello. So quickly, I have sat here and made most of the slides. So that just looks into a couple of things which we thought was not very much discussed. Some of the basic things are over here which we'll go for discussion today. So our topic is comprehensive genomic profiling of the tumors. Yes, for the couple of lectures we have seen, we are moving towards, in oncology, a comprehensive panel, and that's what CPG stands for. Now, coming quickly to Dr. Nidhi. Yes, how will you look into a tumor? I don't want you to get into details, but from the molecular or pathology point of view, you have diagnosed a new case, and what are the things you need at this point of time as a clinician? Leave radiology, leave clinical pictures. From the tissue, what you want.
So apart from the IHC, which will tell us the type of malignancy, in certain cancers like breast cancer, lung cancer, colon cancer, uterine cancers, we definitely need to look into targets for targeted therapies, so IHC, PCR or NGS accordingly.
Yeah, you're right, Nidhi. We need to look into the histopathology, we need cytology, we need the targeting, we need the DNA analysis, RNA, and other precision if facilities and logistics are in place. Yes, coming to Dr. Mansi. Yes, Dr. Mansi, would you like to go a little beyond in this, after what she has said? Something more you want to do? Want to know? Facilities are available?
Yeah, so we would also get NGS done on the solid tissue as well as liquid biopsy in certain cancers, especially lung cancers and colon cancers on recurrence mainly. But basically we are looking at targets for added therapy along with chemotherapy or replacing chemotherapy.
So as a clinician, you want to look into some targets which you can target at this point of time, utilizing all the facilities. And coming to Dr. Nitesh, Okay, quickly to you. Anything else you would like to know? You have everything in Fortis. And you have the patient also. You need to have the patient. Hmm. Hmm.
All day in the morning, it's becoming more imperative that we want to know everything we can about the tumor, not only from point of view of what we can target, but is the target likely to work? Will be early resistance? Do we need to monitor that or not? What is the likely steps forward? So I want to know everything about the tumor, and I will want
Which
to
will
know.
help us as a clinician.
Yeah, I want to know everything about the tumor, which will help me as a clinician, because I want to first take the first step, then to monitor. So I want to know everything possible, including TMB, MSI, germline,
Yeah,
somatic.
whatever it is. Whatever I have with me. Okay. What is preferred? Coming to Dr. Amit quickly, just for everybody. We heard everything about NGS. There may be questions of PCR, Sanger sequence, DNA, RNA. Why do we choose NGS? Because this was not discussed. Why do we choose NGS? Yeah.
The sensitivity.
Can we have the sound little higher in that? Why we boil down to NGS? Yeah, Amit, quickly.
So it's
to
primarily the
points.
sensitivity that I would go for.
Mainly because of the sensitivity. Yes, we now stop targeting sequences, exons, and we go for the whole genome. Why do we choose NGS? Yes, Amit has already highlighted that is high, it is multiplex, we get different answers, and it is over a period of time we have learned how to do, and more data, small amount of material is needed, and that's why CPG or the NGS has become the platform. Yes. Now coming to Doctor, your name is? Dr. Abhinash.
Yes.
Yes, Dr. Abhinash. You heard all the lectures from the morning. What is your concept for CPG?
So basically, we are trying to look for any mutations available, either for DNA mutations and variations and the rearrangements. Ultimately, you are looking to target any of those things, along with the tumor mutation burden and other markers for immunotherapy as well.
So you have learned good amount of CGP today. Yes, what you said is nice. Basic classification helps us to predict treatment. What Nitesh said, prognosticate, value, how to improve, how to go for targeted drugs. And that's what our discussion today was, to how it benefits the people.
So sorry, if I may just interrupt over
Yes,
here.
yes.
I kind of slightly disagree to this. I mean, the purpose of doing an NGS or any of these purposes should not be for exploring treatment based on the reports that comes out. It should rather be the other way around, that whatever approved treatments are there to match if those alterations or indications for those treatment are there in the report, because these reports will always give you plurality, huge number of alterations, for there would be likelihood of some treatment options available, but then it has to be taken with caution. So going it the other way around, it would be more prudent, why one should really go on for an NGS.
NGS and guide your treatment. So the next sequence generation, NGS is the standard which is to be followed. Now, liquid biopsy, again, going to Dr. Amit quickly. Liquid biopsy, when will you do? How does it help you? And do we do both together? Quickly.
Do you mean to say, should we be doing concurrent or shouldn't we doing concurrent? So that's something defined more by the economics and also the context on what disease. And
you have both available. Patient is willing to give the blood.
So not all the stages of cancer and not all cancer type, the liquid biopsy would going to give you the results what you would really. If the tissue biopsy is available, and depending on the context on what it is, concurrent may not always be necessary, even though it may be desirable.
Can I just add to that? And I do buy the cost question, but we are very short of trying to analyze this. That wrong testing cost is at least 3 to 4 times more, or missing something 3 to 4 times more than actually the right testing cost. We've now got a series of 4. We are finding about 7 or 8 more patients where something as simple as EGFR or ROS1 was missed, and they ended up obviously on chemo and immunotherapy, because most of these patients end up doing. And so both in terms of...
is preferable, yeah.
So I would do the best test first, I'm not saying one must do complementary, but I will do the best test first.
Yes, Dr. Nidhi, quickly.
And specifically some mutations like PIK3CA at relapse in HR positive, HER2 negative, ESR1, for which we have data on liquid biopsy, that also is one field where we would prefer to use it.
So preferably first line is tissue, second line tissue and liquid biopsy, if possible, both together so that we don't make any misses. Yes, Dr. Abhinash, molecular tumor board, and I think it's a new concept coming up. So you agree in that, and whom you want?
Definitely I agree for that, but unfortunately I'm working in second tier city where I am alone. I think as Dr. Raja was putting it up, I mean, you are alone sometimes, so I belong to that category. So I have to take decision on my own.
We can take phone calls.
Yeah,
we heard we can just call up
we do, yeah.
and then get the results. Yes, that's what we do. Okay, so comprehensive genomic panel. Quickly, that's one of our cases. Coming to Dr. Mansi. Okay, that's what the report we got. In a lung cancer tissue, you send it. These are very simple clinical cases. As a clinician, I'm presenting, not the difficult ones which we heard in the morning. So I'm sure you're in the same platform. So Mansi, what will you order? You have a lung cancer biopsy sample with you. So, forget about the report. Report is just, I put it to initiate discussion. We don't get into clinical part. It's a metastatic, non-onset, non-adenocarcinoma.
Yeah, so we do send the tissue, at the first diagnosis at least, and we send it for EGFR, AL cross, PD-L1 at least. If possible, we also add for HER2, for KRAS. We do have small panels available. If the patient can afford, I would send the entire NGS panel, I mean the whole genome sequencing as well. In this particular patient, I see good news. I see EGFR exon 19 deletion, and then I would offer him EGFR targeted therapy.
So there are 8 genes panel, 10 genes panel, 12, 56, 125, 256, 350. So which one will you do?
So again, it depends on the patient's affordability. If
patient can afford, may not afford, would you ask them to spend?
I would send the basic panel first on the tissue, and then if needed, if it is not fitting into my clinical, assumption, like if it's a non-smoker, based on the age, based on the gender, then we would send for more. But we would at least need EGFR, AL cross, PD-L1, minimum.
Basic 8 to 10, which is a standard guidelines, should be done, and that's why we brought this case here. So that is minimum requirement. Whether you do more than that, that's what's done by LILAC for us is on the tissue.
But Dr. Ramesh, isn't the guideline evolving? Because if you look at even something, as much as we'll have to hate it, NCCNO last 3 to 5 years, it has gone from at least do this to now saying do comprehensive. And the reason for that is not because EGFR will be missed, or the reason for that is we are finding that there are multitude of interactions between different mutations, and they have to be understood. I have a patient with ALK variant 1 mutation, but she also has a P53, and she also has a second ALK mutation.
I'll show you some cases with this.
So it just gets difficult.
Of course, if the patient can afford, and if we can
No, I'm arguing against that. I'm saying if a patient can't afford the test, it's not a question. The patient can't afford the therapy is the question. If they can afford the therapy, please spend money on the right test.
Exactly, the basic tests at least.
Basic, no, he's saying expand the panel.
Basic right
test. Right test,
No,
okay?
So the endeavor should be, as what I totally agree with what Nidesh is saying, the endeavor should be to understand the biology. And the understanding of, it's not just about spending out money of like getting genes which may not immediately be of like an help or like something that you may be able to act clinically upon. It's because we really do not understand the natural history of the cancer, and at these and the sample is precious. Several other aspects that kind of like comes into the picture.
So it depends upon the patient, the doctor, the environment, finance, insurance, and then take a decision what you are going to send at that point of time. If it is yes, plus minus, we restrict to what she said. If nothing is an issue, you send a broader panel and keep it. Okay,
There could be a MET amplification, co-MET amplification in here.
There is, we had a positive exon 19. Coming to another, this thing. We got this test. Again, breast, Nidhi, what will you do? In a breast, what will you send? Metastatic breast. Nidhi,
In a metastatic breast.
I just gave a report to keep the discussion going.
Yeah, so in a metastatic breast, ER, PR, HER2/neu, AR, and Ki67 to begin with. And then we have other options like PIK3CA, P10, germline, or somatic BRCA, PALP2, that is additional. But to begin with, ER, PR, AR, Ki67, and HER2/neu.
HER2/neu. And see, this was one of our reports which came positive for the cells analyzed for the HER2 positive. Coming to, again, Dr. Nitish, for immunotherapy, is this report enough? We had this one of our patients. We did it from Lilac and sites. Or you need some more information. It's a metastatic tumor.
So more or less this CPS score is less than 1, isn't it?
TPS is less than 1.
And CPS less than 1. It's on 263, so I could question that. But if I'm very confident of my pathologist and their ability, I could kind of accept this. My only problem is 263 usually tends to do CPS, so I'm accepting it. Otherwise, I may have that. Maybe Amit, your views on that?
Yeah, another case similar.
This is breast we are talking about?
Breast.
No, any cancer. I didn't put any tissue there.
Okay. Okay. I mean, and so I totally agree. I mean, it all depends on, one has to be aware of the, what specific antibody is kind of like being used, because it's very different for, the thresholds are different.
Platform, yeah, platform use. So this is one of the reporting, or anything else you need beyond this? No, I think so. Coming to BRCA 1 and 2.
I would have liked MMR now, because it's tumor agnostic marker.
MMR, MSI, some more markers,
MSI,
TPS, TMB, all those things will be needed. Now, Dr. Abhinash, this is one patient. I think this patient is ovarian cancer. Ovarian, endometrial, both cancers at both sides, metastatic disease. We did the biopsy. It's on the block again, newly diagnosed case.
So probably I think...
do we need to do anything else to tell that you don't need?
HRD testing would be better than BRCA alone nowadays.
So, yes, very good. That's all. What we did for the BRCA 1 and 2, it was negative, and then subsequently we send the samples for
But
further.
that's only for ovarian, right?
Yeah, ovary, it has multiple metastatic sites. Okay. Rare tumors, again, rare tumors in an important area. CPG has found, I think we didn't discuss today. So yes, utilize in rare tumors, rare mutations that will help us. Coming quickly to lung cancer, again, going back from the last, Dr. Mansi. Yes, this is one of our patients. Again, to roll the discussion, okay, so it is an EGFR positive tumor, L8R, L858R. I think you have already told about it, that these are to be done, and then T53 was not showing. There was a pathogenic T53. I want comment from you. Report was positive for 2.
So this helps us in prognosticating for sure. But would I change the treatment plan? I don't think so.
Not so. Thank you. That's it. Another lung cancer case. Yes, Nidhi, quickly. This patient came from the northeast. We did presented with spine meds, adenocarcinoma lung. Okay, so this was the report.
So again, ROS1 positive. So we have crizotinib. We have.
No, see the ROS1. See, it's just less than 1%. We even didn't know what to do. He had pain. We did spinal stabilization. Report took some time from Lilac to come. Just 2 weeks they gave the report, but before that he was in a hurry. We have to start treatment. He wants to take the everything and go back. So ROS is less than 1%.
Okay,
T53 is positive. All other mutations negative.
Okay, in the slide we cannot see the percentage. So I mentioned crizotinib. Of course, as Dr. Mansi said, if TP53 is positive, it shows a worse prognosis.
Yeah, Dr. Abhinash or Dr. Nitish, is less than 1%. I think ROS was for this particular case.
But even then, I think probably I would use crizotinib.
That's on the tissue?
Yeah, on the tissue.
Okay, I still, it's a fusion protein, is very strong driver.
It's a strong
I
driver.
would be tempted to start with that, but with caution, because it's
Sorry,
low.
yes. No, we started also with chemotherapy, okay, and then this report came, and this person's body surface area was little low and he was little short height, so we gave half the dose of, started with crizotinib, he has taken the drugs and gone back to the northeast. We reduce the, why I said, because you mentioned about the price. Because Ross doesn't have any of the drugs which has a generic here. Yeah, others were there. Now,
So
quickly, colon
these
cancer.
kind of fusion events are very rare events, okay? I mean, if you're finding it, it is a significant finding and it overrides all other. This is the rarest of the rare kind event to happen with two different breakpoints and then joining again together. Stochastically, this is not possible. But if you would allow, may I ask a question to Nitesh quickly with regards to the EGFR earlier that you were there, and that was the P53 alteration. So yes, going for EGFR-directed therapy is fine. Would you be comfortable putting in bevacizumab, given that the TP53 mutations?
So if we end up with a lengthy discussion, these are the patients, you have to take a call on, do we do that upfront or at progression? And at progression, these patients actually do very well with ramucirumab, because that's second line anyway, and that's VEGF as well, and taxane. But yes, there have been some high volume disease, especially with pleural effusion with P53 and a patient deletion 19, where I actually chose to start osimertinib with bevacizumab for that reason. Yeah.
Yes, coming to another, it's a colon cancer. Father was diagnosed, recently diagnosed, metastatic colon cancer. That was the peripheral blood we got. He had the surgery done here or somewhere else, and then we only had the blood to do. So that was the report, T53 and APC. So how do you proceed? And son is 27 years old. He said, can I check? So we did a colon hereditary, and it was seen that nothing was seen in him. So can you correlate and give some opinion? Dr. Abhinash, and then Nitesh, you can start.
Can I ask this question to Amit? Is blood good enough to pick up a APC? Well, this patient had APC as well as P53, and my guess is really from a colonoscopy perspective, the son wants to look at APC, or I want the son to look at APC. But is the blood good enough to pick up APC?
Yes, I mean, APC would be a deletion. I mean, so it should be able to kind of like pick up in there. But in this specific case, I would want to know whether it is a left-sided or the right-sided, because that would be something that will help me define what kind of treatment that you would.
Left-sided tumor.
Okay.
The question is sun screening. That's the question,
Right,
isn't it?
pardon.
Your
No, this
question
was-
is, how should the sun screen for cancer?
Yeah, no, son wanted the same test to be done, so we sent it together. Okay. So
Without any indication.
So hereditary testing, with a few lines on colon cancer. Father is having this mutation positive. So we screened it, and then this was the no variant of significance was detected. Okay, so that was the results. And then quickly, one case of ovarian cancer. That's the report, Dr. Abhinash. Again, advanced serous adenocarcinoma was evaluated, and extensive disease.
So it is HRD positive, HRR positive?
Yeah. These are all recently diagnosed cases. Yeah.
So
There is positivity. Okay, BRCA1 is positive. Non-HRR gene is
HRD
positive. CNB status is positive.
so
What should I tell?
definitely we would use PARP inhibitors if they are indicated.
Yeah. Okay, for these tests. Anybody, Nitesh, you want to add? This is a newly diagnosed, recent case.
I'm really questioning platinum role again in life. So I would go for platinum.
Yeah, they
and
got
base-
chemotherapy. Now we
Yeah,
have
so
just done the chemo.
post-chemotherapy.
There is residual disease. So we sent the sample. They want to know what can we do beyond this.
I don't know what to do with a VUS on a BRCA, and I don't know what to do with the FGFR amplification of ovarian CA. So I'll have to get Amit and have a long conversation with him.
Or give
So I
benefit
would
of
go into
doubt.
the details of the BRCA1 mutation, what exactly, I mean, why it is VUS and what it is, and based on that, the decision
Yeah.
would be. This is an incomplete
Yeah,
by
we may
itself.
go for a further testing or give benefit of
No,
doubt.
further analysis of what exactly this
Even
is.
in
before
second
taking-
line, rucaparib has approval without the testing. You don't need to do. Drugs like rucaparib can be used. Okay, so we are planning, not yet started. Endometrial cancer, yes, there's a big role for molecular subtyping. It's already there in the classification. And this is one of the patients with PDL1 scoring. We have already seen the earlier scoring. So these are what has to be done. We had a couple of endometrial cancer. Coming to unknown primary, once again, Dr. Abhinash, comments on unknown primary. Is it an area like the rare tumor where you need a comprehensive genomic planning?
think this is one area
profiling.
where definitely we would love to do upfront CGP analysis, because
Yeah,
we don't
these are
know.
areas not for discussion. Yes, we need to do. Does all our panelists, Nidhi and Mansi, agree with that? Rare tumors and tumors with metastatic where we don't know and patient wants further therapy, do we need to do? Yes. So that brings us, I think, last slide. Yes, CGP helps us to give us the actionable mutation, tells us what to do. There is precision oncology. It's not that it has to be a very extensive panel, very expensive. Yes, patient-friendly panels are available. They are available financially. I think over a period of time, insurance is also going to cover, because it's the way forward for all of us. Patients are there. They want the drug, and if you don't do, then it may be a problem, but then discuss with the patient, discuss with everybody, and then ask for the test. And always talk to the company. Thanks to Lilac Insights, we'll pick up the call. He told, pick them up. I will tell them, patient can't afford, please do it. And there's people to do for you. And we are in the era of molecular. So again, to everybody in the house, do you confidently believe that we need NGS for CPG? I think yes. Everybody needs it. Thank you very much, and that brings us to the end of our talk. Thanking you. Nice to be here.
Thank you, ma'am. And thank you to all the panelists. Now we have the next talk about cytogenetics and cytogenomics and precision oncology. To talk upon that, I call Dr. Prochi Madan, Honorary Consultant Geneticist, Jaslok Hospital, Mumbai.
Pardon? Yeah, yeah. So I started my career in human cytogenetics in 1973 after master's in botany. And the rest is history. Anyway, so today I'll be talking not only on cytogenetics, karyotyping, fish microarray, but cytogenomics, which is optical genome mapping, which is coming up. And together with NGS, this is like the best test now, though it is currently being used mainly for a lot of research for validation by BioNano, but it will come soon. So there's karyotyping. Maybe you can just follow the arrow. Karyotyping, fish, microarray, what I told you. And optical genome mapping is also coming. And all of you know karyotyping is with banding. When I started in 73, there was no banding also in India. And then gradually all the techniques developed. And you can develop, I mean, you can find everything, the aneuploidies, deletion, duplication, and everything. And the fish, of course, you all know that there are different, so it's like counting the colored dots. And normal report would be having just 2 green and 2 orange in most of them. And then you can have a fusion. And the probes have developed also from a single fusion to the double fusion. And then we have extra signal probes also. And then there is the chromosome microarray, which is also very useful for detecting microdeletions, duplications. But microarray does not pick up any balanced rearrangements. So this is what I'm talking about, cytogenomics. And this is the figure for optical genome mapping, as you can see on the board. So they have a circus plot. And it can detect even the balanced rearrangements. It can detect amplification. It can detect repeats. So together with next generation sequencing, this is now like the maximum that can be done today. So you can see over here, if there's a translocation from chromosome 11 to 22, this line just shows that this is the translocation. And so the technologies have been developing. And so you all know the advantages of fish and karyotyping. Just to give a few examples, clonal evolution in karyotyping. So this was a small child with HLH, And on initial diagnosis, only this translocation of 822 was seen, if you can follow the arrow. The child was given some treatment, and there was total remission, but then again there was a relapse, and then we found clonal evolution. So on the right-hand side, besides the 8 and 22, there was a 3 and 21 translocation. And then that evolved further. And besides that, then you had so there was an additional 1q, and that 1q went on chromosome 21. So this is clonal evolution. And then the patient again, prior to bone marrow, they again did a karyotyping, and they showed still further abnormalities. And so that is how we give our reports. And then again, karyotyping can be used for chromosome breakage studies. So in Fanconi's anemia, we find these radials, and with bleomycin, you can see the breaks in ataxia telangiectasia, and also sister chromatid exchange, as you can see here on the right. So one chromatid is stained dark and one is stained light. And if there is an exchange between the two, the dark and light have exchange places, then so you have to do it also on a control sample, and the control should show a few breaks. Only then you know that your technique is working. And a positive patient should show almost on every chromosome multiple breaks. So this is how it works. And so you all know that fish is very rapid, so those are the advantages of fish also. And then you can detect deletions. So this is a case of deletion 6q. And you can see that this was an interstitial deletion. So this is the normal chromosome 6, if you follow the arrow. And here you can see both the breakpoints, but the distance between them is reduced. So that is an interstitial deletion. And that particular region which was deleted was the MYB region. And so there's only a single signal over here. Similarly, you can have the 11q23 deletions of ATM. Or here, this is isochromosome 17q, which means that 17p is deleted, the TP53. So again, over here, you will see only one orange signal. So this is how we interpret the results. And then again, in MDS, if there is only deletion 5q, then you all know that lenalidomide can be used. You know, some cases have additional 7q deletion. This case had a missing Y also. So these are just some examples. And then we have the break-apart probes. So with genes like the translocations of MLL, IGH, etc., it can be translocated with multiple chromosomes. Sort of, how do you know? You can't do so many fish tests. So they have taken out the break-apart probes. And if that is positive, then you can do a reflex fish with the same probe on a metaphase. And you will find out that where the translocation has gone. So just one example over here. So this was a 911. So the MLL showed a break apart. So the normal is the fusion signal. And if there's a translocation, there's a green and an orange together. So over here, you will see that the normal 11 on the right is the fusion signal. There's only one green, which is on the chromosome 11. You can see that the banded and the fish images are together. And on top, this the signal has gone onto chromosome 9. And so that was a 911 translocation. And then again, the fish is used for HER2, as you all know. And you can see the normal cell with just 2 greens and 2 orange. And this is amplification, the extra greens and only 2 orange in the HER2 positive cases. Similarly, for bladder carcinoma, we have the Eurovision fish test, and there 5 colored chromosomes are used. And the yellow signal is for the P16 gene on 9p, so that gene is deleted. So you see in the abnormal case only 1 yellow, and the other chromosomes 3, 7, 17, they are additional, there's trisomy. So this is a positive case. And fish can detect it earlier, and so you can also, it's on a urine sample, and so you can sort of, get a better idea of either a relapse or a disease. And this was one interesting case where IHC was 0, negative for HER2, but when the fish was asked for by the doctor, and we found that the fish was positive. So it means that we need extra vigilance and maybe do fish on more IHC negative cases. And now this is just comparison of the different techniques, and it shows that the karyotyping fish microarray and the optical genome mapping. And optical genome mapping together with NGS will give the best result. And so this, the BioNano is the company which is doing this test. And recently only they had their symposium just a few days ago. And Dr. Alkacha Obe, she's over here, she's giving a talk. And this is how you see the difference. So whether there is a translocation or a deletion, you see it by these different maps. And here again, so this is cryptic translocation between chromosomes 1 and 2, and also there is the other 514 translocation. And then here again, besides the translocation, there are additional deletions. You can see these red dots are the deletions. And here there's a 3-way translocation with the Philadelphia chromosome. So this is how the circus plot shows. And this last one is a case with multiple translocations, and that may not have been detected on any other test. So just an example of how all this can help in precision medicine depending on what is picked up. So you all know that cytogenetics and cytogenomics, they help for the detection, identification of the tumor molecular signatures and in understanding cancer initiation and progression. And optical genome mapping together with NGS has led to a fast identification of several candidate biomarkers associated with diagnosis, prognosis, and therapeutics. So this is just that I'm part of the IVF laboratory in Jaslok, and we are now doing pre-implantation genetic diagnosis where, so this is a case of a female whose mother had breast cancer and the mother had the BRCA mutation. So this lady also got tested. She was asymptomatic, but she had the mutation. She did not want to pass it on to her kid. So they opted for IVF, and embryo biopsy was done on day 5. And there are multiple embryos which are developed. So those were sent for testing. And then the embryo, which was free of the BRCA mutation, was transferred. And she gave birth to normal twins. So it's like this. You can use any of the other hereditary cancer sort of probes also. And so this is one of the examples. Thank you, as we are running short of time here. Sure.
Thank you, ma'am. Now we have a last talk for the day by Dr. Gowar Shafi, who is a chief medical geneticist, One Cell Diagnostics, to talk about CGP as guides for resistance or response to immunotherapy.
Thank you so much for giving us this opportunity. And as we heard, a lot has been discussed on CGP, its role in clinical setting. So some of them might be repeat. I'll just highlight how we can use CGP and how we should actually take benefit of the finding in CGP in terms of defining whether patient could benefit with immunotherapy or not. So what I'll be talking about a little bit about immunotherapy basic, immunotherapy response prediction, and more importantly, these emerging biomarkers for immunotherapy resistance and sensitivity. So if we look at this, the cancer immune cycle, it starts with when cancer is there and it starts releasing the cancer antigens. And these cancer antigens are presented by dendritic cells, antigen presenting cells to T cells to prime and activate them. And after activation of these T cells, they are rushed into the tumor where they get activated and they recognize the tumor cells and therefore start killing the cancer cells. That's how normally it should happen. But what we see is also when you have these innate and adaptive immune response to activate these T cells to kill the cancer cells. But at the same time, the cancer is so smart, it tries to, induce the environment, what we call tumor microenvironment, therefore, create a suppressive tumor environment or a cold tumor environment. And these all are related to the various genes and the pathways which help them to release these cytokine factors and create a cold tumor environment there. So that gives the ability to evade the immune system, which is one of the hallmark of the cancer right now. We know that recruitment of immunosuppressed cells, ineffective presentation of tumor antigens to T cells, and the release of immunosuppressive factors, cytokines, and then these T cell checkpoint deregulations. This is what becomes very important. Multiple checkpoints are there, and they get deregulated, and that's how the cancer cells take the advantage of that. And there are many more ways the tumor can avoid immune detection. And we know these tumor cells, release the receptors to present new antigens, inhibitory molecules, immune cell, tumor infiltrating lymphocytes, secrete certain cytokines, regulatory T cells, and the microenvironment. And if you see the right side on the picture, that lot of genes, and they are involved in all this microenvironment, which defines whether it's going to be hot or cold tumor. So, as we talk about, most of the time, PD-L1 is the important biomarker for defining the immunotherapy. And now, lately, we have seen tumor mutation burden, microsatellite instability. But the relationship between these TMB, MSI, PD-L1 is so complex, and it differs from cancer to cancer. And therefore, this is where it becomes important when we have to take a decision based on these markers. How can we, utilize the information of genomic alteration from comprehensive genomic profiling to define which patient could likely respond to immunotherapy or not. So let's discuss some of the emerging biomarkers which could define the sensitivity and resistance to immunotherapy beyond these PD-L1, MSI, and TMB. We know that HLA pathway is important and has demonstrated the response to immunotherapy. Interferon gamma pathway is important. JAK state, which is actually contributes the resistance to immune checkpoint inhibitors. TGF-beta again creates a cold environment. So how can we identify genomic alterations and then define whether patient is going to respond? So one of the things which we often make miss is mutational signatures, particularly ApoBec mutation signature. It is important, and data has shown that the patients who have mutation signatures like ApoBec high, and along with tumor mutation burden, actually they have a enhanced response to immunotherapy. And the reason behind that is these ApoBec mutation signatures actually increase the neoantigen burden, tumor mutation burden, therefore the patient could benefit better compared to those who do not have. There is another biomarker called CDK12, particularly inactivation mutation or loss of function mutation in this has shown to response to immunotherapy. And there has been studies, particularly in prostate cancer, where biallelic activation of this leads to a better response to immunotherapy. There has been seen that exceptional PSA response has been observed in patients with metastatic castrate-resistant prostate cancer who were treated with immunotherapy. And these CDK12 loss actually leads to a lot of neoantigen burden and FTB burden, and leads to gene-wise fusion accumulation there, and therefore patients could benefit with immunotherapy. And this is most often we get is KRAS STK11, and this has been very important finding that when we have a KRAS positive, particularly non-small cell lung cancer, they respond to immunotherapy. However, when we have KRAS co-occurring with STK11, these patients do not respond to immunotherapy. This is how it becomes very important now, irrespective of PD-L1 status or TMB status. This becomes important. But there is a third thing there. If you look at the data, TP53. So what we have seen that combination or co-occurring of KRAS and TP53 has the highest response compared to KRAS alone, as well as KRAS and STK11. And here I just want to highlight one case, moderately differentiated adenocarcinoma of colon. PET scan suggests primary colonic malignancies. histopath is moderately differential adenocarcinoma grade 2, has received 1 cycle of FOLFOX here. And when we do the analysis, we found the co-occurring KRAS G12D and TP53. Looking in the previous data, if you have KRAS G12D and TP53 has the highest response. And this is how actually this is going to help you to define patients who might benefit with immunotherapy irrespective of PD-L1 status. So another case, lung adenocarcinoma, who was a past smoker, EGFR negative, was treated with heavily, and what we have found is the P10, MSI was stable, tumor mutation but 12 mutation per megabase, PD-L1 positivity was 13%, HRD score was 16%. This is how you can combine P10, HRD as well as tumor mutation burden along with PD-L1 status, decide whether patient could benefit with immunotherapy. So another case of urinary bladder cancer, 65-year-old with hypertension, and CT scan has shown consistent with soft tissue mass. TUB guided biopsy was done. Surgery was done. Neoadjuvant therapy was not given. PET scan has shown there is some negative in that time. Because of that, adjuvant therapy was not given. 5 months later, the patient has shown cough, chronic cough, and PET scan again found mass. And then, bronchial cross-copy biopsy has shown metastatic carcinoma. So here, if you look at that, there are a huge number of mutations has been identified here. CCND1 amplification, MYC amplification, FGF3, FGF4 amplification, FGF19 amplification. Then you have ATRX mutation. A huge number of mutation. And tumor mutation burden 14 mutations per megabase. PD-L1 on tissue was 12% CPS score. So this becomes important, what to do in such scenarios. That's where that, the interpretation of these comprehensive genome profiling becomes important. Looking at the amplification here, as well as, this CREB mutation. So what it has shown that particularly these amplifications occur in 11q13. So why it becomes important, most of this FGF family are there. This FGF family has been shown that, this is leading to resistance to immunotherapy. More particularly, the patients who have these 11q30 have shown hyperprogression on immunotherapy. And this becomes important. There is a lot of data. When we have such scenarios, then how you can avoid actually immunotherapy, upfront if by doing comprehensive genomic profiling. So another case, again, bladder cancer metastatic to liver and lymph nodes. So what we have seen is MDM2 amplification, again in the 11q part. And though we have this TMB high, PD-L1 is positive, but because of MDM2 amplification, the patient might not respond to the immunotherapy. So another high-grade neuroendocrine carcinoma, possibly of ovarian origin, pelvic mass was detected. CT chest shows lung nodules. 3 cycles of carboplatin paclitaxel was given. Biopsy shows poorly differentiated carcinoma with neuroendocrine differentiation. Then PET positive for pelvic mass node, reduction in lung niche. So underwent multiple post-chemo surgeries. Biopsy shows, T1 C2 disease, PET was positive, recurrent disease, surgical pathology reports, high-grade neuroendocrine carcinoma. 4 cycles of, etoposide cisplatin was given. And when NGS was done, what has been found is CTNNB1, even though we have high TMB and PD-L1 positive, HRD was negative. But because of CTNNB1, what we know is Wnt beta-catenin pathway plays an important role in, cold immune environment. When we have this beta-catenin signaling is active, and then you have cold tumor environment, and patients do not respond to immunotherapy. So this suggests that, why we need to go beyond PD-L1 or MSI, TMB. To conclude, understanding genomic findings and its correlation with response and resistance to immunotherapy is very important. And more importantly, immunotherapy is very expensive. We always talk about financial toxicity. The resistance mechanism, identifying upfront before we start immunotherapy based on PD-L1 becomes very important. However, we have seen a lot of emerging biomarkers is coming up. More data is needed to see the actual benefit to the patients. Thank you so much.
Thank you, sir. That was the last talk for today. I request Dr. Nitesh Rothagi, sir, to close the session for us.
Thank you. I know there are very few people in the room now, but thank you, Dr. Gohar. Thank you, ma'am. But really, this was a great 2 days, and today was exceptionally good. Precision medicine is very close to my heart, as most of you know. My guess is this is going to change every 6 months. So whatever we've learned today, I think is going to last for 6 months, maybe 3, but certainly not 9. So do enjoy the rest of the day, and thank you very much for being here and spending time with us. Thank you.